Welcome to our virtual workshop on endpoints for diabetic retinal disease based on the Neurovascular unit. This workshop is serving as the kickoff event of the Endpoints consensus building process of the Diabetic Retinal Disease Cure Accelerator, which is a collaborative effort of the Mary Tyler Moore Vision Initiative and the CCOI. I'm Dr. S. Robert Levine, the founder and CEO of the Mary Tyler Moore Vision Initiative, or MTM Vision. First, some background on what brings us to this moment. My wife, Mary Tyler Moore, was an optimist. She thought anything was possible, and this hopeful attitude, even in the face of great personal challenges, including her vision loss from diabetic retinal disease, inspired the founding of MTM Vision. And it is the scope and urgency of the problem of diabetic retinal disease, or DRD, that motivates us to action. Many of you know recent data from the Surgeon Today studies demonstrated alarming rates of DRD in youth and young adults, with greater than 50% showing evidence of disease after a mean diabetes duration of only 12 years and at a mean age of 26.4. And of course, each of the over 530 million people and growing with diabetes in the world is at risk for DRD. Finally, DRD is the most common and most feared severe complication of diabetes. Our mission and approach are to accelerate development of medical products to eliminate vision loss in people with diabetes through the breaking down of barriers to progress. The three fundamental obstacles to progress we have identified are: you can't solve a problem you have not defined, you can't cure a human disease without studying the human condition, and you can't judge success unless you know what to measure. Our response has been to help better define DRD via an expert process designed to inform an update of the DRD staging system, to facilitate the study of the human condition by establishing a research-driven ocular biorepository and building a data and specimen sharing platform to engage academia and industry in collaborative research, and the design of clinical studies to validate promising functional endpoints, along with the launch with CCOI of an endpoints consensus building process, of which this virtual workshop is a part. We believe that to better diagnose, predict risk of progression, improve patient selection for clinical trials and care, and assess treatment efficacy requires an updated DRD staging system. We therefore organized a working group process to help identify promising endpoints and biomarkers in people with diabetes relevant to the multiple dimensions of DRD that include retinal vascular disease, retinal neuronal disease, visual function, basic and cellular mechanisms, systemic disease, and quality of life. Each working group published its findings in Ophthalmology Science, and these findings have guided our additional efforts and inform our consensus building process. Our biorepository has been stood up, its SOPs refined, and we are undertaking deep characterization and omic analysis on the first group of human ocular tissue and fluids collected. The data generated and specimens collected are shareable with academic collaborators and industry members of our pre-competitive consortium, with our dedicated secure online data sharing platform launching this summer. An additional outcome of our staging update process has been the design of two clinical studies, one natural history study and the other a post-treatment observational study, to assess promising functional endpoints in DRD as measured by commercially available FDA-certified devices. Our top-line goal for these studies is to validate new visual function primary endpoints and surrogate markers that are acceptable for use in clinical trials for regulatory approval of innovative medical products, including those for potential use in early-stage disease. Another outcome of our staging update was confirmation of the need for a new PRO for DRD, which could better assess patient experience, social emotional factors, and visual limitations associated with the degeneration of different retinal cell types. This project is near completion thanks to generous funding from our corporate partner, Boehringer Ingelheim. The item list generated in this project may also have application in assessment of patient-reported outcomes relevant to other neurodegenerative disorders of the retina, such as glaucoma and AMD, which we know is the goal of the broader NEI collaborative effort on PROs led by Emily Chu. To summarize, there is an urgent need to identify, validate, and build consensus on novel endpoints to assess retinal health in people with diabetes, to guide clinical research and medical product development, and enhance patient care. We recognize that DRD affects the entire retinal neurovascular unit, and we need the capacity to objectively assess the relationships between retinal structure and function. We listen to the voices of patients in all we do. Our overarching goal is to facilitate the development of new medical products to prevent and cure vision loss from diabetic retinal disease. And finally, this virtual workshop is the kickoff of the Mary Tyler Moore Vision Initiative, CCOI, DRD Cure Accelerator's consensus-building efforts on endpoints and biomarkers for DRD. We will follow up with the publishing of insights gained to be shared with the broader community for feedback, and then hope to generate a white paper for distribution to stakeholders ahead of our fall symposium on curing vision loss from diabetes, which will be held in Ann Arbor, Michigan on November 3rd, and to which you will all be invited. It is now my great pleasure to introduce Dr. Jennifer Sun, who, in addition to serving as the scientific co-director of the Mary Tyler Moore Vision Initiative, is a professor of ophthalmology at Harvard Medical School, an actively practicing vitreoretinal surgeon at Joslin Diabetes Center, and the chair of diabetes initiatives for the DRCR Retina Network. Dr. Sun will lead our first session entitled Clinical Assessment of Retinal Structure. Jenny?
Welcome to our first session. I'm the moderator, Dr. Jennifer Sun, from the Harvard Department of Ophthalmology, Joslin Diabetes Center. And our first talks will focus on endpoints related to clinical assessment of retinal structure. Our first two talks will discuss methods to assess and evidence regarding the role of retinal non-perfusion in diabetic retinal disease. We'll then shift gears in our second two talks to abnormalities in neural retinal structure in DRD. We'll focus first on early neurodegenerative changes and then on later stage disorganization of retinal layers that may directly impact visual function. I'd now like to welcome Dr. Paulo Silva, an associate professor at Harvard Medical School and my colleague at Joslin Diabetes Center. Dr. Silva, along with Lloyd Pauliello at the Joslin, has led many of the studies that have informed our understanding of the role of ultra-wide field retinal imaging in DRD. And he'll be discussing retinal non-perfusion and future risk of vision-threatening complications.
Thank you, Jenny, for that great introduction. So I'll be speaking on retinal non-perfusion and future risk of vision-threatening complications. Retinal non-perfusion is a key pathologic hallmark of diabetic retinopathy. It can be found in eyes without clinically visible or mild disease, but generally increases with disease severity. It's been associated with an increased risk for future DR worsening, as well as DR biomarkers, including retinal leakage, central macular thickening, predominantly peripheral lesions, and increased intraocular VEGF levels. This graph shows non-perfusion extent stratified by DR severity on the x-axis. As DR severity increases, the extent of retinal non-perfusion area is increased. This trend is evident from no DR until severe NPDR, where it levels off. We evaluated the distribution of non-perfusion across the posterior pole, the mid-periphery, and far periphery. This figure shows the total distribution of non-perfusion stratified by DR severity. Comparing eyes with no DR to eyes with PDR, the proportion of non-perfusion in the mid-periphery and posterior retina increased by 1.5 and 6-fold respectively. Our observations have shown that in eyes with NPDR, worse DR severity was consistently associated with increasing non-perfusion on ultra-wide field FA. Non-perfusion was located initially in the mid-peripheral retina across all levels of DR and progresses posteriorly with increasing DR severity. We also evaluated DR disease worsening and extent of non-perfusion. This figure shows the risk of DR worsening by tertiles of baseline non-perfusion on FA. Eyes with the greatest amount of non-perfusion have the highest risk of DR worsening. This table shows the association of non-perfusion in each retinal zone with DR worsening. Increasing non-perfusion in the posterior pole and mid-periphery were significantly associated with increased DR worsening. Similarly, with increasing overall non-perfusion, there's a significantly increased risk of developing PDR and vitreous hemorrhage. In the protocol AA cohort, after multivariable modeling, increasing non-perfusion on FA was independently associated with an increased risk of DR worsening. The AA data shows us that increasing baseline retinal non-perfusion on ultrawide field FA is associated with increased risk of DR worsening or treatment over time, as well as secondary outcomes such as PDR and vitreous hemorrhage over time. These associations are driven by non-perfusion located primarily in the posterior pole and retinal mid-periphery. We also performed exploratory analysis of this AA data to evaluate the associations of retinal non-perfusion with vision-threatening complications. Vision-threatening complications, as defined here, were used in the analysis. In the AA cohort, 41.1% developed vision-threatening complications over the 4 years of follow-up, with PDR onset in 31%, and center-involved diabetic macular edema in 23.5%. So this figure, shows retinal non-perfusion and its association with vision-threatening complications. As you can see, baseline total non-perfusion was significantly elevated in eyes that developed PDR or concurrent PDR and CIDME within 1 and 2 years. In this cohort, total non-perfusion was not significantly elevated more than 2 years before any outcome. These two figures show the onset of vision-threatening complications and non-perfusion in the posterior pole and retinal mid-periphery. As you can see, elevated baseline total non-perfusion in the posterior pole or mid-periphery were again significantly associated with the onset of PDR within 2 years. This figure shows the onset of PDR and non-perfusion in each retinal zone. We can see the strongest association between baseline non-perfusion and eyes that develop PDR onset within 1 and 2 years. Each 0.1 unit increase in posterior baseline non-perfusion was associated with a 3.7-fold increased risk of PDR onset within 1 year. So in summary, greater baseline retinal non-perfusion was strongly associated with the onset of PDR within the first 2 years. This highlights the potential value of retinal non-perfusion as an early biomarker for identifying eyes at high risk for diabetes-related vision-threatening retinal complications. Retinal non-perfusion commonly begins in the retinal mid-periphery and advances towards the posterior pole as DR severity increases. Progression of retinal non-perfusion into the posterior pole show the strongest associations of PDR onset within 2 years. To conclude, these results suggest that progression of retinal non-perfusion to posterior pole may be an important risk predictor of PDR onset that can identify eyes at risk for rapid disease worsening and development of vision-threatening complications. Furthermore, establishing agreement and clinical consensus among clinicians and researchers on the optimal standardized methods for quantifying retinal non-perfusion and integrating these metrics into current DR severity scales will be important to most accurately identify patients at higher risk for vision-threatening complications and improve patient outcomes. Thank you.
Thank you so much, Dr. Silva. Our next speaker will be Dr. Yali Jha, who is Professor of Ophthalmology and Biomedical Engineering and the Jenny P. Weeks Professor of Ophthalmology, as well as the Associate Director of the Center for Ophthalmic Optics and Lasers at Oregon Health and Science University. Dr. Jha is one of the world's leading experts on OCTA metrics, and she will speak on AI-driven assessment of non-perfusion on OCTA.
Thank you, Jenny. Hello, I'm Yali Jia from OHSU. I want to thank the invitation from Dr. Jennifer Sun and the opportunity offered by Mary Taylor Moore Vision Initiative Foundation. That's a great opportunity for me to share my work on AI-driven assessment of non-perfusion using OCT angiography and its potential as a robust imaging endpoint. Here are my financial disclosures. OCT angiography is a functional extension of OCT using intrinsic motion contrast to image retina macrovasculature. Since our group introduced split spectrum amplitude decorrelation angiography in 2012, OCTA has become a standard clinical tool and received its own CPT code this year. Compared to fluorescein angiography, OCTA provides high-resolution layer-specific images without dye injection. It allows quantitative analysis of deeper capillary plexuses that are affected early in diabetic retinopathy. This illustration compares vessel density and non-perfusion area, two common type method to quantify perfusion status. In a good quality scan, vessels appear continuous and density is high. Poor quality scans break vessels, falsely lowering density value. But non-perfusion area based on intercapillary dropout remains very stable, making it less dependent on scan quality. Our 2023 BGO study confirmed this. Vessel density drops with signal loss, but non-perfusion area remains consistent, especially when measured using AI. Over the years, we have developed the key technology projection resolved OCT angiography that can help us visualize three distinct retinal layers. Based on this technology, we developed a rule-based method to quantify non-perfusion area by detecting enlarged intercapillary space. Our study shows plexus-specific MPA distinguish the level of DR with greater sensitivity than inner retinal MPA. The MPA on superficial layer is usually more prominent in DR. However, rule-based method is vulnerable to artifacts. AI provides significant advantage here, especially across variable quantity scans, so we can gain access to the data from a lower quality database. Expanding the field of view from 3 to 6 millimeter improves MPA detection. This is very important in diabetic retinopathy, where lesions may extend beyond the central macula. However, the shadow becomes more prevalent on larger scans. Deep learning model allowed us to build context-aware artifacts resilient detection of MPA, especially in the low-quality scans with confounding signal attenuation effect due to shadow or defocus. This method uses multi-channel input, including thickness map and OCT reflectance, to minimize false positives. It can accurately distinguish real non-perfusion area in blue and shadow artifacts in yellow. We carefully validate this approach by placing an iris diaphragm or a filament in front of the eye to simulate signal attenuation artifacts, pupil vignetting, and floater shadows on healthy eyes. We also tuned the autofocus parameters and generated 3 types of defocus scans. Our AI model consistently distinguishes true MPA, here is foveal avascular area, from shadow regions, even under the severe signal loss. This rigorous test gives us high confidence in the model robustness. In real-world clinical images from healthy eyes with shadow artifacts, our AI model correctly labeled MPA and avoided false detection due to shadow. This accuracy is critical for reliable quantification, especially for the multi-site studies. In collaboration with Dr. Jennifer Sun, we tested MPA detection and quantification methods on DRCR OCTA datasets. Both AI and rule-based methods were tested on a few hundred eyes. This plot shows the severity distribution. It seems that AI method tends to pick up those smaller MPA regions that were identified by the grader. In contrast, the rule-based method failed to identify some MPA in regions with a very strong noise background. As shown in this ROC analysis, AI significantly outperformed a rule-based approach in detecting both referable and vision-threatening DR across most plexuses. This supports AI-based MPA as a strong candidate for a quantitative biomarker. Importantly, MPA is not equivalent to ETDRS severity scores. Here you can see 2 eyes with the same score but different MPA size. Smaller MPA can be demonstrated in a high score. To expand the field view, my team built a prototype wide field system using 500 kHz swab source laser. This enables visualize much larger area, critical for the peripheral MPA analysis and potentially stronger correlation with ETDRS grading system. To summarize, MPA is more stable than vessel density method. AI segmentation improved detection and reduced the artifacts. For the future work, I'm more interested to investigate the wide field and the plexus-specific MPA for predicting DR progress, although we have already shown some promise in our earlier work. I want to thank my dedicated research team and our collaborators at Casey and investigators at DRCR. I am also grateful for the support from a funding agency. Thank you for your attention. I need to hand it back to Dr. Jennifer Sun. Thank you.
Thank you, Dr. Jha, for that terrific talk. I'd now like to welcome Dr. Elliot Sohn, who is the Endowed Chair of Diabetic Retinopathy Research and Professor of Ophthalmology and Visual Sciences at the University of Iowa. Dr. Sohn is widely known for his translational research expertise in retina, including recent investigations into retinal layer segmentation to understand retinal neural layer thinning as an early predictor of DRD outcomes. He will now give his talk titled Retinal Neurodegeneration May Precede Microvascular Changes Characteristic of Diabetic Retinopathy in Diabetes Mellitus.
Thank you, Dr. Sun, for that introduction. It is such an honor to be with all of you today on this webinar. Thank you again to the organizers for the invitation as well to be here with you. I have no relevant financial disclosures to this talk. So the clinical forms of diabetic retinopathy are widely recognized worldwide. We see this as non-proliferative and proliferative forms of diabetic retinopathy and clinically significant macular edema. Now, this has been seen in the retina for decades, since the early 1960s and 1950 here with Kogan and Friedenwald, seeing dilated capillaries, aneurysms, microaneurysms in the retina of patients with diabetes. But more recently, diabetic retinal neurodegeneration, which is what I'm going to be spending my time talking to you about in this session, is becoming increasingly recognized by not just researchers, but now even clinicians around the world. So what is diabetic retinal neurodegeneration, DRN? Well, one way to kind of show you in picture form here is looking at these two donor eyes. On the left is a human with diabetes but no retinopathy, and on the right is an age-matched control. And you can see in red the RPE down at the bottom. The inner retina is at the top of this, where you can see it's labeled in green, labeling the NFL and GCL in these human donor eyes. And what you can see is that in the human with diabetes, you see a thinning of the inner retina compared to the control. Now, when we looked at 6 and 6 of these eyes for a total of 12 eyes, we did see that the NFL GCL was significantly thinner in patients with diabetes and no retinopathy compared to these age-matched controls. So then we also wanted to look at the capillaries. Was there any difference in the microvasculature that we could detect? And there was no difference in capillary density between these two groups. So diabetic retinal neurodegeneration is loss of neuronal structures in the retina associated with diabetes. Now, this can come in several different forms, but we are focusing primarily on the NFL, GCL, IPL layers here, but this has also been seen in the photoreceptor layer as well as some other layers in the retina. So loss of these neuronal structures can occur without evidence of microvascular changes in diabetes. Now, this isn't the first time that this has been described. In the early 1960s, Woolton, Ashton suggested that diabetic retinopathy could result from intraretinal degeneration, and Bloodworth also described intraretinal loss from diabetes. And then in an experimental model in 1998, Barber and others published a seminal paper showing apoptosis and ganglion cell loss in diabetic rats, suggesting this diabetic retinal neuroretinal degeneration does exist. But now we have OCT image analysis that can look at these retinal layers and see to just sub-micron level, 0.2 micron, using our automated OCT quantification of these layers with the publicly available Iowa reference algorithms. This is below the resolution that you would see with a clinical OCT unit. As you can see from some of the work that we've done years ago, you can see all these retinal layers are being automatically segmented with this publicly available algorithm. So what we did was we looked at 45 patients in a prospective longitudinal study in type 1 diabetes. With these patients had no to minimal diabetic retinopathy, and we followed them for an average of 70 or median of 73 months of follow-up. And we used our Iowa reference algorithms to automatically quantify the intraretinal layers. So what you can see here is one patient with diabetes and no retinopathy, year 1 on the left, year 4 on the right, where you can see the NFL and the GCL IPL layers really do thin over this 4-year period. So when we calculate these 45 patients and look at the overall loss of these structures, we see a 0.25 micron for NFL and 0.29 micron per year loss in GC IPL over time. This comprises a total of 0.54 micron per year intraretinal loss that happens in patients with diabetes with no to minimal diabetic retinopathy. This is independent of age and glycemic control, but dependent on the duration of diabetes. And when you look at this over years, over decades, what you start to see is intraretinal loss that's similar to rates seen in moderate to severe glaucoma. So then we have to ask ourselves, well, does DRN actually precede vascular changes from diabetes? Is there a way to show this, prove this? Well, I'm going to show you some data just from one animal model. We looked at 2 in our paper here, but just this one animal model of mice in type 1 form using STZ, streptozotocin, to induce diabetes. And we looked at 6 and 20 weeks duration diabetes using OCT. And then we also looked histologically at vessels, capillaries, pericytes, and ganglion cells to compare the differences between these 2 groups of animals. So we used our Iowa reference algorithms for automating this quantification of these intraretinal layers and the other layers in these mice, and this is publicly available as well for mice. What we saw was NFL GCL thinning in the diabetics compared to controls, even at 6 weeks. You can see that on the left here. But at 20 weeks, the difference between the inner retina, between the diabetics and controls, was even more marked. When we looked at ganglion cell density, we didn't see a change at 6 weeks, but we did see this at 20 weeks, where the ganglion cell loss was seen in the diabetics compared to the controls. So looking at the vasculature, we didn't see a difference between the diabetics and controls in acellular capillaries or pericytes at 6 weeks. So to summarize the work done in mice, inner retinal loss is seen on OCT in a more sensitive manner than we saw histologically, but then there was no change in vasculature, retinal pericytes, acellular capillaries, vessel labeling, 20 weeks, did not see any difference between the two groups. So this does really suggest that DRN can be seen with no change in microvasculature, at least in this type 1 model versus controls. And we had a type 2 model that we replicated this as well. So other research groups around the world have seen this, not just in the macula, but also looking at the peripapillary NFL GCL layers, seeing this thinning in humans with diabetes with no to minimal diabetic retinopathy. It's also been demonstrated in animal models. And we've also seen multiple groups showing electrophysiologic detection of inner retinal loss, as well as loss of inner retinal function in eyes with no to minimal diabetic retinopathy. So there are certainly implications that are widespread of DRN. A couple of them listed here. Could this be the earliest manifestation of diabetic eye disease? Could this apply to most, if not all, patients with diabetes? The functional impact of diabetic retinal neuropathy is just starting to be realized, and the role of the neurovascular unit and how DRN plays a role in that is also critical. I know that's going to be a session that Dr. Gardner is going to moderate later in this webinar. More recently, just this year, Carol Chung's group out of Hong Kong did a prospective cohort study looking at 385 eyes with no diabetic retinopathy or NPDR baseline. And what was found was thinner GCL IPL thinning that was significantly associated with a higher risk of not just DR development, but also progression of DR and PDR development. And when you include GC-IPL thickness, this actually helps improve the predictive discrimination for those that will develop diabetic retinopathy. So, in conclusion, diabetes causes an insidious progressive loss of the inner retina that's independent of vasculopathy that can be detected microscopically even, that's independent of glycemic control. And these functional abnormalities, which I didn't get to talk about in depth here, but they can be seen before clinical features of diabetic retinopathy are seen. Early detection of this and diabetic retinal disease might allow prevention of diabetic retinopathy. How? Well, stabilization of the neurovascular unit in diabetes. If we can stop neuronal loss, it's possible because of the tight-knit neurovascular unit. You might also be able to help prevent patients from developing diabetic retinopathy and future vision loss. Thank you very much for your attention, and I'm happy to turn this back to you, Dr. Sun.
Thank you, Dr. Sun. We are delighted to have Dr. Stella Vujcevic as our last speaker. She is professor and head of the medical retina unit of the University Eye Clinic at San Giuseppe Hospital in Milano, Italy. She is a leading voice in vascular and degenerative retinal and choroidal diseases with a particular interest in imaging, biochemical, and molecular biomarkers. She will speak on disorganization of retinal inner and outer layers and visual function in diabetic retinopathy.
Thank you, Jennifer, for the kind introduction. I'm Stella Vujcevic from the University of Milan, and my presentation will be on disorganization of retinal inner and outer layers and visual function in diabetic retinopathy. These are my financial disclosures, none relevant to this presentation. So patients with diabetes mellitus have microvascular, neurodegenerative, and neuroinflammatory modifications in the retina that ultimately lead to the clinical signs of diabetic retinopathy. We know that the neurovascular unit is composed of different cells within the retina, and they have different roles, and they are crucial in the integrity of the inner blood retinal barrier. The neurovascular unit is composed by retinal vasculature, by retinal glial cells, both the macroglial and microglial cells, and also by the retinal neurons. The neurovascular unit is crucial in maintaining the integrity, as I said, of the inner blood retinal barrier. The microglial cells, amacrine cells, and endothelial cells form the neurovascular unit, and they are part of the inner blood-retinal barrier, which transports 2/3 of the substances across retinal capillaries to extracellular tissue, and 2/3 compared to the 1/3 that is performed by the outer blood-retinal barrier. So the overtime diabetes damages the neurovascular unit, affecting both the anatomical and physiological processes. And that's why we have also at the very early stages of the disease, the functional impairment in the retina. So the visual loss the visual loss that is evaluated by best corrected visual acuity is detected only, let's say, at the late stage of the disease after many years of the disease. But at the early stages of the disease, there is this concept of functional diabetic retinopathy that is due to diabetic retinal neurodegenerations and which precedes the vasculopathy and also the clinical signs of diabetic retinopathy. So actually the functional impairment, which can be detected by some other tests, for example, ERGs or contrast sensitivity, color vision, perimetry, and so on, seems to be much more precocious than actually the decrease in the best corrected visual acuity, which is a high contrast text. So in the context of the neurodegeneration of the retina, there is the concept of the drill, so disorganization of the inner retinal layers, which is the sign on OCT, the absence of detectable boundaries between the ganglion cell inner plexiform layer complex, inner nuclear layer, and outer plexiform layer, firstly described by Jennifer Sun more than 10 years ago. Drill may indicate disorganization of the cells within the inner retinal layers with a dysfunction in the normal cellular activity between the photoreceptors and the ganglion cells. It is associated with the worse visual acuity and also with the severity of diabetic retinopathy. Firstly, it was described and noticed in diabetic macular edema, but then later it has also been described in the resolved diabetic macular edema, as you can see here on the image on your right side. Not just the disorganization of the inner retinal layers, but also the outer retinal layers, especially the EZ of the photoreceptors, can be damaged. And then in this case, it has been called the DROL, so disorganization of the outer retinal layers. A recent paper showed that in diabetics type 1, the early intensive glycemic management and controls lowers the risk of development of drill and macular edema. A change in drill extension was proposed as a prognostic biomarker in diabetic macular edema and also center-involved DME, and also as a predictive biomarker of visual acuity in response to the treatment in DME. And some groups have shown that, for example, when treating DME with anti-VEGF drugs, the presence at baseline, for example, of drills and some other signs such as hyperreflective spots of foci, disruption of the outer retinal layers, are all associated with the worst prognosis after anti-VEGF treatment. And other groups have shown that actually the patients with DME and drill, if they are treated with the intravitreal steroids, there seems to be a decrease in the extension of the drill when evaluated on OCT. Drill has also been associated with the presence of the ischemia in the macula and neuronal changes, and also with the changes of the ellipsoid zone of the photoreceptors. And the ischemia that has been described also is the multi-level ischemia, so involving both the superficial but especially the deeper capillary plexus. And also, for example, in patients with macular ischemia that have stable PDR and have the drill, and E-zeta loss, it was shown that the visual acuity is much lower than in patients without these characteristics. In a recent paper that published by our group, we evaluated several grades of severity of the disorganization of retinal layers. So inner retinal layers DRIL, then outer retinal layers DROL, and then also when E-zeta is involved, we called it DROL plus. And we found that in these cases, there was a much higher functional impairment, both when evaluated best corrected visual acuity and also retinal sensitivity that was evaluated with the microperimetry. And also there was major changes in the microvascular parameters evaluated with the OCTA. So the perfusion and vessel density of the ICP and DCP were significantly decreased in cases with the disorganization of retinal layers, as well as there was a major choriocapillaris flow voids. These were increased with the major severity of the disorganization of retinal layers. A recent prospective study that evaluated the incidence of visual loss in patients with DMI showed that when you have the presence of DRIL, these cases will probably develop a visual functional loss compared to the cases without the presence of the DRIL at baseline. Now, with the novel OCT machines such as the high resolution OCT, there is the possibility to evaluate even better these DRILs. And also it was shown that DRIL progresses in the vertical way, so from the inner retinal layers to the outer retinal layers much more than in the extension or horizontal layer. And the AI recently was applied also to evaluate the DRILs and to measure it. And the identification of DRILs at baseline may be useful in clinical trials for stratifying, for example, patients based on their prognosis. So to conclude, DRIL may indicate disorganization of the cells within inner retinal layers, and also it is associated with major functional impairment in these patients. Microperimetry and visual acuity can detect the visual impairment in these cases, and it seems that the disorganization of retinal layers that involve outer retinal layers and E-zeta loss are those correlated to major functional impairment and also to the ischemia at the deeper retinal layers. With this, I have finished, and I pass on you, Jennifer, for the rest of the meeting. Thank you.
Thank you so much, Dr. Vujicevic, for that fascinating presentation. We now have time for open discussion with our speakers as our panel. And as they join us in this live session, I'll note that we're very happy to take questions and comments from the audience. So please feel free to send in your questions and we'll address them. Thank you so much, everyone, to our fabulous speakers. We're now joined by our panel that includes Dr. Silva, Dr. Vujicevic, and Drs. Tom Gardner and Michael Abramoff as well, subbing in for Dr. Joey Jha and Elliot Sohn. I'll start with some questions, and we've had some wonderful questions from the audience. I'll say we'll try and prioritize the addressing of questions related specifically to endpoint development in diabetic retinal disease. So, although your talk on non-perfusion assessment and ultra-wide field FA, was also followed by Yali's discussion of non-perfusion grading in OCTA. Can you talk a little bit about your thoughts about contributions of central versus peripheral non-perfusion, and what work is needed to move forward some of the findings on these imaging modalities as potential endpoints in this field?
Yeah, Jenny, that's an excellent question. So our work, as well as work from histologic samples, have shown that retinal non-perfusion in diabetic retinopathy starts in the mid-periphery and progresses centrally. And our work with ultra-wide field fluorescein angiography has shown that you can have extensive peripheral ischemia and very minimal central ischemia. So what's critically important is that peripheral to central spread, because once we have non-perfusion in the central macula, we get irreversible visual loss, we get rapid progression of disease. So the focus should really be on identifying and monitoring peripheral non-perfusion early, ideally before central non-perfusion occurs, so that we can potentially intervene sooner and more effectively. I think both ultra-wide field FA and OCTA provide complementary information. when we look at the ultra-wide field angiogram, we detect early peripheral ischemia, and OCTA, which is very non-invasive, we can see peripheral central non-perfusion that we've seen is highly predictive of visual loss, of progression to PDR and center-involved macular edema. But I think the ultimate goal is to identify patients whose peripheral non-perfusion, wherein the disease is just confined out in the periphery before it progresses to the central posterior pole, to be able to preserve vision longer. And we do need to be able to integrate both the central non-perfusion and the peripheral non-perfusion into staging systems and treatment algorithms that can reflect this dynamic interaction between the central non-perfusion and the periphery.
Wonderful. Thank you so much, Paulo. Michael, you have engaged in the work with Elliot Sohn on diabetic neurodegeneration and certainly have been an important proponent of recognizing early neurodegeneration in diabetic retinal disease. We have a question from the audience from Dr. Ilya Du asking whether the neurodegeneration we see in diabetes, do you think it's uniformly occurring before microvascular changes? And, any thoughts about, is the neurodegeneration driving microvascular changes? Could there be vice versa? What do we know about neuroprotection in diabetic retinal disease as well?
Yeah, it's a great, and it's been a few years since we did this study, and I want to apologize for Dr. Sohn, who's in clinic right now. So I have to stand in for him, and thank you for having me. I think I did a paper about this where I said that diabetic retinal disease is a neurodegenerative disease, meaning it starts with that. But we are all discussing proxies or cascades, right? Maybe it's true that diabetes causes neurodegenerative changes, which then cause vascular occlusion, which then causes ischemia, which you then see in OCTA, which then causes VGF, which then causes all the things we know and we are trying to prevent. The problem is always ultimately about endpoints, that you want to have something that is cheap, very accessible, patient-friendly, and as early in the disease can be, because unfortunately, whatever we're discussing, diabetic neurodegeneration or the ischemic component or even the macular edema, there are chronic diseases, they take years to manifest. And that means that the trials will take really long, and we want to bring this to patients sooner rather than later. So how can we find endpoints that are early in the disease and that are accessible to treatments and management early on? And so that's where I think neurodegeneration still has a role. It's still not clear whether some patients have neurodegeneration, and aside from that, an ischemic component, right? That three-dimensional, thing that we always talk about, or is it a cascade where one necessarily comes before the other? But either way, it would be good to have recognized endpoints based on neurodegeneration, which I think will be more likely to be functional, because the structural changes like loss of ganglion cells, nerve fiber layer, typically take at least months and probably years to manifest. So I think there's a big role for electrophysiology there. Since you asked about neurodegeneration and the difference among patients, we still don't know that. Whether we all get it and then we get ischemia, or whether we get neurodegeneration totally independent of ischemia.
Thank you, Michael. Yeah, it's a really important discussion, and I'll ask Tom. You talked about the importance of functional endpoints that can reflect neurodegeneration. As we start to develop those functional endpoints, and I know we'll have a comment from that later. I think one of our questions is, what are the structural endpoints that we perhaps should be looking at along with those? Stella, I see you've got your hand up. Comment from you.
Now, I wanted to ask Michael about the question that you asked him: is neurodegeneration preceding the microvascular or vice versa changes? Do you think, Michael, that maybe we can have, let's say, different phenotypes? Sometimes that we have first the neurodegeneration, then microvascular damage, and some cases that are first microvascular damage, at least detectable, and then neurodegeneration.
Oh, absolutely. And right now, I don't know. I don't think we know. But clearly, in the prospective study that we did, in that paper that Dr. Sohn was discussing, there was a big difference between patients in terms of how much ischemia they also developed. And it was almost independent from how much, NFL and GCL lost. This was on Stratus. Don't forget, it was very primitive. But yeah, I totally agree.
Okay, so maybe that's something that still keeps us, let's say, for not knowing exactly which mechanism is maybe the first one, and sometimes it is one and sometimes it's other. That's okay.
But bringing it back to the key, we need something very, very early. Right? So we can intervene early, and we know the results of the trial early, and we get it to patients next year or whatever, not 10 years from now.
Of course. Okay. Thank you.
And I think, it brings up the question, are there standard variables that we should be capturing in our clinical studies, across studies for patients with diabetic retinal disease? Tom, you've again been a big proponent in terms of the recognition of the neural components of diabetic retinal disease. What's the basket of endpoints that you'd be interested in to look at both early neurodegeneration and maybe later stage neural disease?
Right. Well, I think the protocol is AR and AS that the DRCR Retina Network and the MTM have set up should help go a long ways to answering that. And we have 3 functional tests: the frequency doubling. The Conan's objective field analyzer, the AST contrast sensitivity device, and the pupillometric assessment with the LKC ERG machine. And I think these, combined with the standard clinical structural methods that we've been using for a long time, should go a long ways to answering that question. So I'm really excited even to get those studies started, and even the baseline data will be very important. But particularly study AR, the one that has the longitudinal data, will be the one that will really give us the kind of information that Michael and Paulo are talking about, and Stella.
Yeah, we'll certainly have an enormous amount of very detailed information, both structural and functional characteristic of patients in the natural history of the disease, and then in eyes undergoing treatment with anti-VEGF or DME from those studies. I think again, as we think about how we validate new markers or new potential primary endpoints in this field, let's move on to sort of later stage neural disease. And Stella, you gave us a beautiful talk about both DRIL and DROL. David Antonetti in the questions in chat pointed out absolutely rightly that in general, retinal thinning, as we look at as a structural marker, has been fairly poorly correlated with vision loss. And he has pointed out mouse models of diabetes, but of course we see that in patients also. So can you talk a little bit about, do you see a path forward for these markers? Do we find that they're better correlated than just central subfield thickness with eventual visual acuity or concurrent visual acuity?
Thank you for this question, Jennifer, because this is really an important point. The central retinal thickness, we know that it is really only moderately correlated to visual acuity in patients with DME. So that's definitely not our best parameter to be correlated, let's say, with the function. The present, for example, that I showed, the DRIL and DROLs are, I would say, quite late clinical signs of the neurodegeneration. The earlier signs with Elliot shown are those of the thinning of the inner, just the thinning of the inner retinal layers. So the DRIL and especially the DROL, they have been correlated to visual acuity, and even you showed it as I showed before a lot of years ago, that it is correlated to the decrease in visual function. We know that the DRIL are not correlated to central retinal thickness because we can have resolved edema, but we still can have the disorganization of the retinal layers. So what I think we need now is to understand even more this clinical OCT sign of DRIL and also further DROL, in the sense, how does it correlate to ischemia, for example? That may be something that can even bring us even to the, let's say, more not so advanced stages, but even a little bit more precautious and longitudinal studies, definitely, to understand how does it change over time and how does it affect the visual function over time.
Well, thanks so much, Stella. I agree; those are really important points. We'll head back to the sort of the retinal vascular side of things, and there've been a number of questions talking about methodology and, how do we, I think, Paula, you raised this point in your talk. It's going to be important for us as a field to come together to standardize both our methods of assessment and then come to a consensus on how many of these markers should be used. Paula, can you talk a little bit about what considerations are important for you in the grading of retinal non-perfusion, particularly on ultra wide field imaging? I'll note that Amita Damapalli mentioned in the chat that in her experience, many of the eyes, I think that she's seeing have received anti-VEGF injections that may form artifacts that then shadow the angiogram. So how do you deal with this? Or do you deal with this in model performance, or do you just recommend imaging before anti-VEGF injections?
That's right. So Jenny, I think it's very hard and there are very much a lot of unknowns. So all the work that we've done is only based on the clinical trial work from AA and some of the early work that we've done from the Jocelyn studies. But I think, since there's such a huge potential for AI to be able to do these gradings, so they do it for the OCTAs. I think for the wide field angiograms, for greater standardization across the different grading centers is really to be able to leverage the AI databases to use the manually annotated work that we've done for Protocol AA, combine it with other collaborators that have also done similar manual annotations to be able to look at a model that can potentially provide us with an outcome or a metric that can be standardized.
Mm-hmm. Perfect. Still a comment from you?
Yeah, can I have one, let's say, methodological question for Paolo, who is a great expert in grading the non-perfusion. So Paolo, is the fact that, let's say, the very far periphery non-perfusion, it seems that it is less important than the mid-periphery and posterior pole periphery, is it due to the difficulty in grading the images and having, very well imaged the far periphery, or it is something really actual?
Yeah, so I think the far periphery, there's a lot of variability, even among eyes. The size of the globe, the axial length is a factor because there's a lot of peripheral retina that can be naturally non-perfused, especially in longer eyes, which we don't see. We don't see the perfusion out in the periphery. Also, the imaging modality provides a lot of artifacts. So we get lid and lashes from the optos images, and that somewhat increases the variability, especially in the far periphery. But we've seen the correlations with the mid-periphery and the posterior pole to be very high for disease progression, development of vision-threatening outcomes.
Perfect.
Thank you.
So we've got just a few minutes left in our panel discussion. I'd like to actually go to just a rapid fire question and answer for each of our panelists. We've talked in some detail, and we've heard really wonderful talks about retinal non-perfusion. We've heard about neural retinal layer thinning and early neurodegeneration of the retina, as well as later stage measures of disorganization for both the inner and outer layers. Let me ask the panel one by one. Are there potential endpoints that we should also be thinking about, either structurally from a vascular or a neural standpoint in the retina? What else floats to the surface as you think about promising things that are associated with future outcomes in the eye with diabetic retinal disease? Paula, I'll start with you. Vascular or neural retina?
Yeah, so we want to look for markers for retinal non-perfusion that are not on the angiogram. So markers on color fundus photos. It's impossible to have everyone undergo an angiogram. So we want to be able to look at for non-invasive ways to act as a surrogate marker of the amount of non-perfusion in the eyes. This can be vessel caliber. This can be retinal oximetry with varying wavelengths of laser light. But I think the key here is not to do an angiogram, but to get that information out of a color photograph.
Perfect. Tom, what are your highlights?
Well, my dream would be to be able to quantify at least relative metabolic activity in different regions of the retina, so that we actually see what the retina is doing in its normal, very highly metabolic state, and how that's changed by diabetes. It's technically challenging, but some very smart people are working on this. But that would be, but to be able to add that type of functional information to the standard structural, vascular, and neural observations would really be very helpful.
Yes, that would be wonderful to have that window into metabolic activity. Michael?
Yeah, I will second Tom. I mean, not about neurodegeneration, but the vascular component. If we can do oximetry, real oximetry, we're essentially looking at why there's VGF, which is why all these phenotypes like non-perfusion exist, right? And so if we were able to measure oximetry, that would be, one very early endpoint, if we can get it accepted as an endpoint and tied to outcome.
Fascinating. And Stella, I'll let you have.
So I go even into smaller vessels with the OCTA and non-invasive, obviously, imaging of the macula. I like very much the use of the AI for the evaluation of the non-perfusion. That is definitely something interesting, and I think it can help for the evaluation of other neurodegenerative parameters along the way of the disease.
Yeah, certainly the ability of AI, and Michael, of course, has done tremendous work here getting AI systems that are critically applicable and important in our screening. But the ability also to look for features that we may not identify with the human eye is very promising. I'll add, I know we've seen certainly some promising data in terms of retinal leakage on the angiogram. I think it highlights Paulo's point that we need non-invasive ways to measure and assess these things. But certainly there's a lot of promising work. So I will say thank you to all of our panelists, to our speakers, and we turn it over to our next session, led by Dr. Patrice Fort. Thanks so much, everyone.
Thank you, Jenny.
Awesome.
Thank you, Jenny.
Welcome to the second session, a session that will now focus on cellular and molecular markers of DRD and their relationship to retinal function and its perturbation during diabetes. We will have 2 talks in this session that will discuss the work performed to provide the community with a better assessment and understanding of the structure-function correlation using human ocular tissues. These talks will set the stage for a subsequent discussion relative to what we can and need to learn about the human pathophysiology of DRD at various stages of the disease and how it will inform the identification and validation of endpoints in the clinical settings. I now would like to welcome Dr. Chandra Balarathnathsingam, a clinical professor at the University of Western Australia Medical School, Centre for Ophthalmology and Visual Science, affiliated with the Lions Eye Institute. Dr. Balarathnathsingam has led some seminal studies to improve our understanding of the cellular impact of DRD, both in the clinic and in the laboratory setting, giving him a great perspective on the topic of his talk today, the pathophysiology of DRD and its relation to visual function. Chandra?
Thanks, Patrice Ford, for the invitation to present today at the Mary Tyler Moore meeting. Good morning, everyone from Australia. I'm going to give a very brief presentation, just presenting our data on the use of human donor eyes to advance our understanding and knowledge of diabetic retinal diseases. These are my financial disclosures, none of which are relevant to this presentation. Speaking of diabetic retinal diseases, I'm sure that everyone in the audience understands the complexity of this disease, and that's largely because the retina itself is a very complex organ or tissue. With the exception of the brain, it's arguably the most complex tissue in the human body. The paradigm for understanding diabetic retinal diseases these days, it's generally accepted that we can divide the retina into 3 components. We can divide it into the vasculature, which comprises of endothelial cells, smooth muscle cells, pericytes. We have the glial cells, which are the major supporting cells in the retina. And then we have finally the neuronal populations, which include the ganglion cells, the bipolar cells, and the nuclear cells. And the interaction of these 3 cells or components is what we describe as the neurovascular unit. And they work cohesively in the process of diabetic retinal disease. I think it's really important to say that histology is invaluable for understanding diabetic disease mechanisms, but beyond that, it's not just histology that's important, it's human histology, because as we're all aware, we have these fantastic animal models for diabetic retinopathy, but a lot of those models don't have a macula. So it's very hard to extrapolate all of that information to human disease when most of the visual loss really occurs at the macula. So it's critical that we have human donor tissue for our understanding of conditions such as diabetic macular edema and ischemia. High-resolution clinical imaging, of course, has shown major advancements over the past 20 years, and this is the latest generation OCT released by Heidelberg Engineering, which really does allow us now to start looking at structural elements in the retina, very fine detail. You couple that with something like OCT angiography, which has been around, you have a very powerful mechanism for studying clinical disease, both in cross-section and longitudinal fashion. However, it must be remembered that to understand diabetic retinopathy, we really do need to look down at the fine levels and the interactions between different cell components. And yet we can't achieve that using commercial clinical imaging devices that are available. We're still very much reliant on histology. In Australia, the Lions Eye Institute, our group has really optimized this technique of isolated ocular perfusion using human donor tissue for nearly 25 years. And this effectively involves cannulating the central retinal artery or the ciliary artery with glass micropipettes and perfusing each of the retinal circulations with varying antibodies based on what we'd like to study. And this has really been a really useful technique for us to delve down into the mechanisms that cause structural and functional changes within the retina in diabetes. And once we've perfused the tissue with antibiotics, we can now examine the sample with confocal scanning laser microscopy. And really now we can divide the tissue into each of the vascular plexuses. You can divide the tissue into the superficial plexus, the intermediate plexus, and also the deep plexus within the macula. And although this can be done to an extent using OCT angiography and clinical vascular imaging, it's certainly not the level of precision that one needs to understand the stratified way in which diabetic retinal disease influences the vasculature of the macula. Of course, once we have this, very high, highly detailed information and volume of the macula, we can start applying the latest and greatest softwares to study these structural details in 3 dimensions, which is key for our understanding of disease processes. I'm going to quickly provide an overview of where we see the human donor histology at this point in time can be invaluable for advancing our knowledge and the gaps in knowledge for retinopathy. I think the first instance is looking at early detection and biomarkers of early retinal injury. The second, of course, is exploring new therapeutic targets for conditions and complications we have no treatment for. And finally, of course, unraveling new frontiers and disease mechanisms. So if you were to speak about the early detection of diabetic retinopathy, as everyone in the audience would know, the clinical classification of this still goes back to the ETDRS publication published in 1991, which informed us that using color photography, the first sign of retinal injury is the formation of a microaneurysm. And although this is a very useful clinical tool, the histology provides compelling evidence, including research from our group, that microaneurysms, once they form, it already signifies a stage in the disease process where irreversible retinal injury has already taken place. So the state of the art for detecting and screening retinal diseases really is to detect these changes much earlier than when the microaneurysm forms. Using human donor tissue more recently, we've been focusing on the structure known as interpericyte tunneling nanotubules, IPTNTs. These are structures that have been reported in the human brain, and also some beautiful studies on rodent retinas as well, done by the Melbourne group. And we've really been focusing on that in human donor eyes, and they're far more abundant than one would expect. And these are specializations that connect one pericyte to the next, and it really provides a very fine mechanism of regulating and coordinating blood flow between vascular beds that may be separated by 50 or 100 microns. And the communication through these beds is in the form of calcium signaling and mitochondrial movement. We've recently submitted this data for publication where we've looked at changes in IPTNTs in patients that have preclinical retinopathy, so human eyes that don't even manifest a microaneurysm, yet they show diffuse and significant reduction in IPTNT. So if we can visualize these structures clinically, then that's a really useful way of detecting very early retinal injury. The next, of course, is looking at how can we treat retinal ischemia, which is so common in diabetes. It is a very significant cause of irreversible vision loss, and we still don't have a treatment for it. And we've really been leveraging this concept of endothelial dysfunction, which really affects every vascular system in a patient with diabetes. Now, with respect to the eyes, endothelial dysfunction is seen very early in diabetes. Again, in preclinical retinopathy, before we see microaneurysms, we're seeing signs of endothelial hypertrophy, which within capillaries and arterioles, which is leading to luminal narrowing, which is the precursor for vascular occlusion. If we look at specimens with more advanced retinopathy, not just preclinical retinopathy, we see profound proliferation of endothelial cells within arterioles and capillaries to cause complete occlusion of the vessels. Now, this is not a new concept. It certainly has been described many years ago by other investigators, but we're focusing on it to try and understand what triggers the endothelial cells to proliferate. It's very much an energy-dependent and coordinated, deliberate process. So if we can prevent that or reverse that, we may have a viable target for the management of retinal ischemia, or at least the prevention of it. Finally, the one thing we're looking at in great detail now is looking at glial cells in the retina. I think we would all agree that glia are so abundant in retinal tissue, but there's no way of clinically visualizing it, and there's certainly no treatments to modulate the behavior of retinal glia, which I think really would be the game changer in the management of diabetic retinal disease. We've recently started looking at retinal microaneurysms in diabetic patients to look at how the glial cells surrounding it change. And we're finding these very strong associations between sites where microaneurysms form and also where the glial cells remodel. So we don't know what the cause-effect relations are just yet, but what we have found is that if you have significant glial remodeling around microaneurysms, then that is a very strong protector of vascular leakage. So you can see two microaneurysms in this human specimen. The glial proliferation is labeled green. Aneurysm 1, which has a lot of glial cells surrounding it, has no leakage, whereas this adjacent aneurysm with barely any GFAP staining has got diffuse leakage. So I'm just going to end there. This is a very short overview of how powerful human donor histology is and how important it is to our understanding of diabetic retinal diseases. And thank you very much once again, Patrice, for the invitation, and I'll hand this talk back to you.
Thank you so much, Dr. Bartnissingham. Next, I will be presenting on the topic of changes in the retinal neurovascular unit at the cellular level in DRD. I am Dr. Patrice Fort, Associate Professor of Ophthalmology and Visual Sciences at the University of Michigan. I also serve as the Director of the Mary Tyler Moore Vision Ocular Biorepository and Resource Center. As you know, diabetic retinopathy has been described as a microvascular complication with emphasis on vascular perturbation, which is visible, without understanding very clearly the impact on the neuroretina, the invisible part. However, there is much more than what is visible that we need to better know. In addition to the vascular permeability and vascular dysfunction, there is clear evidence now on neuroinflammation associated with glial cell activation, as well as neuronal damage and even cell loss. All in all, it affects the entire neurovascular unit. This is what led us to coin the term diabetic retinal disease rather than diabetic retinopathy, and lead us to really go after what are the changes that are affecting the whole neurovascular unit, and how is diabetes affecting the neuroretina. we really need to get a better and more specific characterization on all the way to the local aspects of DRD. Our strategy has been twofold. First, to perform multiomics analysis of retinal regions and fluids, including vitreous and aqueous humor, to get a global understanding and assessment of what diabetes is doing to the neurovascular unit. And as the technology has been improving, we are now trying to get into more spatial analysis of those changes and assess those in conjunction with phenotyping. On the first level, relative to the general molecular analysis of DRD molecular mechanisms, we have been using human donor tissues and dissecting the different retinal regions, isolating the fovea from the macula, the mid-periphery and the far periphery, in conjunction with the aqueous humor and the vitreous humor, as well as blood samples. We are looking at studying this in conjunction with the clinical phenotyping of those donors with and without diabetes and with and without diabetic retinopathy or diabetic retinal diseases, and perform multiomics analysis, assessing the impact of diabetes on the transcriptome, proteome, lipidomes, and now pushing farther into single cell analysis. By doing so, we get an overview of the impact of diabetes at a different level of the regulation of retinal function through molecular analysis. Here, I'm showing some of the results that we have had looking specifically at proteomic changes, differentiating them between the macula, the peripheral retina, and the vitreous. That highlights how each one of those regions is affected somewhat differently and at different stages of the disease, going from diabetics without DR to diabetics with mild DR and diabetics with severe DR as a factor of the progression of the disease. And on the left-hand side is an overview of the changes of the proteome, whereas on the right-hand side is the type of pathway analysis that we're able to provide and to obtain with those samples. That gives us a more detailed view of how each of those different tissues are affected by the disease. From there, as I mentioned, we are now pushing towards more spatial analysis in conjunction with phenotyping. What that requires is first a detailed phenotyping and grading of the tissues that are obtained and the donors from which they come. For this, we are performing fundus photographs and parallel to the clinic with joint assessment of the retina through OCT analysis. Here showing you the correlation between the fundus on the left-hand side and the corresponding region and assessed by OCT. And we do the same thing for all donors with and without diabetes and DRD. And here is just an example of the type of imaging that we're able to do on those donor tissues, where you can see in this context of an hemorrhage, the OCT imaging corresponding to the same region seen by fundus on the left, and the OCT on the top right. And corresponding below is the OCM, a method that allows us to get higher magnification and higher resolution of those images. We can do that for all types of DRD features to better understand how the neuroretina is affected in that region, the region of those features. As I mentioned, this is an hemorrhage, but we can do that for all sorts of presentations, all the way to laser scar formation and looking at the neurovascular unit around those different features. From there, what we want to do is couple those images with cellular analysis of the neurovascular unit. Here you see a merged image of a couple of regions from the retina from some of our donors from a non-diabetic normal retina. And this corresponds to co-staining using collagen 4 as a marker of the matrix of the vasculature. is in conjunction with a UVA staining marking endothelial cells and cells forming the vessels, as it's been used by some of our collaborators in other groups, including Chandra's group as well as Marcus Whitaker's group, to demonstrate that those can be used to assess some aspects of loss of perfusion in the retina. Here is an example of a region that shows normal perfusion, and we can continue assessment in other contexts. Here, some partial loss of perfusion represented here in the center of the slide, all the way to regions that are correlated with the fundus photograph that I mentioned before, and showing, again, loss of perfusion in conjunction with slight hemorrhage, where you can see blood cells that have invaded the neuroparenchyma. And finally, all the way to regions that are completely that have completely lost perfusion, and that can be used to assess how those regions are showing changes relative to other regions of normal perfusion, including in the same donors. The goal is to use those phenotyping analysis and imaging with cellular analysis of the neurovascular unit using a combination of single nuclei RNA-seq and spatial analysis of specific regions and specific DRD features to identify how those features are affecting, or how the retina around those features is affected. And here is an example on the left-hand side of a first round of analysis that's been done at the level of the single nuclear RNA-seq, showing the identification of all retinal cells. And then on the right-hand side is an example of MELD imaging, looking at the different layers of the retina relative to lipid composition. And the goal is to get after the changes that are affecting the retina in the different stages of the disease compared to the normal retina. As always, this is a group effort, and I want to acknowledge all the people involved in this project. On the left-hand side is the leadership team of the Maritime World Vision Initiative. In the middle, the MTM Vision Biorepository and Resource Center group with Kelly, Corey, and Carmen that are instrumental in driving this whole project. On the right-hand side, my group at the University of Michigan, with Yang, Linda, and Roshana, who have been instrumental in getting this whole project started. And then our collaborators, both at the University of Michigan, as well as in other academic institutions that are helping with different aspects of this project. I now invite you to the open discussion. In this live session, I'll remind you that we will be looking for an interactive session answering questions from the audience. So please feel free to send in your questions and we'll address them.
Hi, everyone. Thank you for joining us for this second session of our workshop. I think the two presentations really highlighted how much we can now correlate vascular changes with neuronal and glial changes in a specific manner, and we need to get a better understanding of how those are associated with the changes that are seen in the clinic and that have been highlighted in that first session, and how that can help us get to new endpoints that are going to be instrumental for us to make progress in assessment and helping patients in the clinic. So for this session, I'm joined by Dr. Michel Pardieu, who is the Vice Chair of Research, Acting Professor of Ophthalmology at Emory University School of Medicine. Michel has led a lot of studies in the field of DR, both using animal models and also working with patients, and especially focusing on different aspects of alteration of ERGs, and with a great perspective on the effect of diabetes on the neurovascular unit. So I'm very happy to have you join us, Michel. I'd love to start this session, part of the session, by having your take on the two talks and the impact on the neurovascular unit and its relationship to function that's been discussed before.
Yeah, thanks, Patrice, for inviting me to join you today. I found both talks very interesting and intriguing. You know, I think one of the challenges that we have is trying to understand all the different components that are changed by diabetes, right, in the retina. And you know, I've been very focused on functional aspects, but we can't ignore the fact that neurons, you know, have to have vascular support, right? So this is a very complicated relationship that they have. So I think looking at the neurovascular unit is almost essential for us to really understand how the retina is actually affected and how the components are working together. And in my lab, we have been doing a lot more in this area as well, looking at the glia, particularly the microglia, and how they are, you know, behaving in the diabetic retina. And so I think it's really important for us to be able to figure this out. And we've been actually using some diabetic mouse models, and of course they are just models, so they're not perfect, and modeling the human retina, but they still provide some insights, I think, about how you know, the hyperglycemia state is actually affecting you know, some of these effects. And so one of the tests, for instance, that we've been doing is a functional test called functional hyperemia, where you can flicker, you know, green light at the retina, and that flickering response, of course, stimulates the neurons. But then what we're doing is we're imaging at the same time the retina with scanning laser ophthalmoscope or OCT, either one, and you can then look at the vessels, the blood vessels, and see them dilate in response to this flickering light. And so you get this ability to actually functionally look at the vascular, you know, dilation that's happening in response to this neural stimulation. So I think that's a really good output for what's happening at that neurovascular unit, right? How is it actually functioning? And I'm not certainly the first one who's looked at it or seeing that there's differences in the diabetic retina. So I think that that's a really intriguing one to look at, to be able to see how is that changing, how is it affected early on, and does that give us clues to this whole process? And you, Patrice, might have some other thoughts about that, or maybe you've you know, tried to do something similar in your work.
Thanks, Michelle. Yeah, I think that sort of links to some of the comments that were made at the end of the previous session relative to having some endpoints that are that we're able to visualize in patients with limited time and limited infrastructure, so that it can be applied. So certainly there's been a lot of work in the context of ophthalmics and looking at structure function in relation with the variation in blood flow or other aspects of this that can be visualized. So it's, yeah, I think it's certainly one of the areas that can be developed and can be looked at in the clinic in conjunction with looking at aspects like what has been presented by Dr. Silva in the previous session relative to areas of non-perfusion and how this is associated with risk of progression. And so trying to identify, I think one of the primary goal that we've identified right now as part of the Maritime World Vision Initiative and the Biorepository Research Center specifically is to figure out any markers, molecular markers that can be detected and that would reflect those changes, but that could be measured and quantified and followed over time in patients. Obviously, there are limitations to this, and the best markers will be those that will be either seen by imaging or seen in the blood. That is always a better access. But having information relative to their correlation with what is happening in the eye, so having some kind of assessment of how they reflect what is seen not only in the aqueous or the vitreous, but that this is linked to what is happening in the retina is really one of the key questions that we're trying to answer at this point.
Yeah, no, that's great. Actually, that leads right to the question that I had about the data that you showed in your talk, which is, if I saw it correctly, in the when you were comparing areas of the eye, and you had vitreous, and then I think you had macula, and the vitreous was the one that was actually showing changes with just the DM samples, right, before you actually had vascular change. And I find that really intriguing. Can you speak a little bit more about that?
Yeah, so this was definitely a surprising finding that the vitreous of diabetic donors without any signs of DR per imaging were actually those that were showing the most changes earlier. They were showing more changes than the retina itself. Now we're currently working on two things. One is confirming this in independent cohorts, and two, assessing how those changes reflect what is happening in the retina, what are the pathways that are associated with this, and which ones are conserved over time, conserved at different stages of the disease versus those that are very specific to that stage, which all of which are interesting to better characterize, because they will give us some of those insights into what Michael Abramoff mentioned, having really early markers of onset even before things can be seen on imaging. That might relate to also what Elliot's son showed relative to those changes even early in thinning of the retina. And so, this is going to be key to better understand those molecular changes and those different stages. But I think that one of the things that we need to consider relative to this is how do we correlate that? How do we mix that with the fact that there was this conversation earlier about the fact that it's heterogeneous, or at least there were discussions relative to the fact that is it homogeneous or heterogeneous, and I would say that it probably is heterogeneous from all the findings we have. And this is a big part of why I think we need to get into a better understanding, a more targeted analysis of regions in those retinas. But then, based on those changes that are seen at the region level, what can we measure in a more systematic way, whether it's blood or vitreous or aqueous, to reflect this and inform us for treatment-specific or identification of biomarkers for each patient.
Yeah, I agree. That would be fantastic, right? To have that kind of an outcome measure that you would be able to use. And yeah, I think the other thing that we also struggle with a bit is how to define, what we should be looking at. So even, in the first talk, one of the comments was how, valuable it is to look at the human macula, which it very much is, and how that, vision loss is the one of the main things that we want to be looking at. But if we also think about the first session and some of the things that were presented there, a lot of the changes that are being seen very early are actually like in the posterior pole, or you're seeing things in the, outside of that macular area. And so I think we have to be aware of, where is the disease starting? And when we kind of try to think about these biomarkers and what we're looking at, I think we have to keep an open mind about all these different parts of the eye and the structures, the neurovascular unit that are happening, and try to remember or try to be aware of what could potentially be a biomarker. Because at the end of the day, the earlier, other people have already said this, I think Michael said it earlier, that the earlier we can detect, the earlier we can treat, treat, the better off. And so that, it's really one of the goals in my lab is just to see what is the earliest biomarker that we can identify.
Thanks, Michelle. We have about a minute left. I think I would just want to make a comment on the fact that, yes, we do want to see things early. There will be also limitations in terms of what we can see or do early because of access and managing risk over impacts. But there's also a lot to be done for patients that are farther down the road, and identification additional treatments is absolutely key. And so that will be one of those things that we're going to have to manage in terms of which directions and what priorities need to be established as we are moving forward with those different projects. Any last comment, Michelle?
No, I think it's great to see all this exciting work moving forward. And I have hope that we'll develop some new biomarkers, which is very exciting.
Great. Thanks, Michelle. So with that, we're going to conclude that second session, and we're going to take a quick recess break, 10 minutes, and we're going to restart promptly at 12:45. And thank you, everyone, for attending this session.
I'm Tom Gardner from the University of Michigan and the Mary Tyler Moore Vision Initiative. Here in session 3, we're going to discuss assessment of function of the retinal neurovascular unit. And we have 3 outstanding contributors. The first is Dr. Jose Alan Sahel from the University of Pittsburgh. The second is Dr. Jason McInerney from the University of Illinois in Chicago. And the third is Dr. Lou Lesmus from AST in California. Dr. Sahel will be discussing measuring functional vision through mobility testing and virtual reality and the learnings from his studies in inherited retinal diseases.
Thank you, Dr. Garner, for inviting me to present on what we try to develop in terms of outcome measures in retinal degeneration. So my talk is not going to be focusing on diabetic retinopathy. I've been working on retinal degeneration for many years. These are my disclosures. Some are relevant to my talk because of the gene therapies we were developing. I've also been working with a lot of people that I cannot thank now, but some of the names are on the slide and some of the pictures on many of these projects. In retinal degeneration, we are facing challenges that probably are relevant for diabetic retinopathy also. We have to tackle the cause of the disease, and in that case, we are trying to tackle that using gene therapy to correct the gene defect. We are at some point trying to protect the remaining cells in the retina, and this is neuroprotection, which is probably a very important topic in this field. And there are stages of a disease where the vision is so low that even protection is no longer relevant. The target cells are dying or are dead. And this is where you want to restore vision using either prosthetic vision or optogenetics or stem cells. But the challenges are multiple. Some are safety challenges. Some are relating to how advanced the stage of the disease is. Some are relevant to whether we want to be palliative or curative. Some are really, are we tackling the cause of the disease or an amplifying pathway? And you can really list the question, but the key questions are really, how do we demonstrate activity? How do we demonstrate that we are restoring vision? And what do we call vision? Is this the type of visual function we test in the clinical setting? Or is this the functional vision that people are using in daily life? And there was a big success a few years ago with gene therapy in retinal degeneration, thanks to the work of many people, especially Jean Bennett and her group, leading to the approval of the first ever gene therapy called Luxturna. And this was based mostly on the functional vision testing or mobility testing. I'm going to show you a movie of the first patient we treated in my group in Paris, which was the first also in Europe, a young girl affected with these RP65 mutations. And she's trying to move in a low luminance level environment, a platform I'm going to talk about in a moment called Street Lab. And she's very slow. She misses many parts. Takes her a lot of time to navigate because she has a very limited vision. She normally should follow the dots on the floor. She doesn't see the dots. And she's being guided very slowly through that. And this is before the therapy. And this was her life before she got the gene therapy. And you have seen many of these movies, but what you will see now is what happened after she got the therapy, a few weeks after, and she's asked to do exactly the same task. And you will see the difference in a short minute, less than that, hopefully. As you will see, she's now able to navigate on her own very fast and performing. And this video, actually, I have 20 videos of that. Many patients have the same type of outcomes. But we were hoping when this happened that this would be really the start of many therapies. And actually, this is the only therapy that has been approved so far, because there is a sort of valley of death, many failures in gene therapies, many difficulties to get approval from the agencies, raising a lot of questions on what is the preclinical package, what are the outcome measures, what are the expectations, how can we design trials that are meaningful, and how do the agencies react to the questions we have and understand the challenges we are facing. And this leads to the fact that there are currently very few gene therapy trials. And as I said, currently not yet any other gene therapy approved. How do we face that? There are many ways to face that. And I just want to propose, on one side, more science, more understanding of the disease and what we are expecting from the therapy. On the other side, an improved dialogue with the agencies. For example, the CBER, the previous director, Peter Marks, offered a platform approach, really trying to capitalize upon the knowledge from one disease to the other. But this is not enough. We need to build a body of knowledge, for example, on natural history. And the example was given by Foundation Fighting Blindness, clearly by the DRCRnet many years ago, and this is modeled after it, actually, trying to understand the evolution of a disease in multiple patients across the world. And this led to analyzing several gene defects, and now we have a universal study trying to detect what is the magnitude of change that is relevant versus the variability of change, the signal to noise, what is a real change, and this is really the repeatability that we are observing, the sensitivity to change in the population, and trying to eliminate the flooring effect, but also the ceiling effect, and what is meaningful for patients. So I will not to spend too much time on that, and I will just want to acknowledge many people that were involved in that. My group has been focusing on developing what we call performance-based testing, which is demonstrating the ability to help the patient in daily life. And we tried to use multiple scales, and I just see the type of testing we use in clinical trials usually, and trying to focus on the type of test that we develop. One of these is a virtual reality testing, but we used to analyze the mobility. You saw the maze for the mobility testing that was used by Spark. And initially, this was based on the Street Lab, a platform in Paris where we are monitoring the impact of low vision in mobility of our patient. This is an example of a patient with low vision, retinitis pigmentosa, the trajectory of a patient, the direction of a gaze, the ability to move around that, and the ability to measure all the type of movement, the gait, the gaze, the trajectory, the head movement, and demonstrating actually a very reproducible responses. For example, the amplitude of the saccade, the rotation of the eyes. We use that to build the most mobility testing, which is virtual reality testing, which was compared to a real-life mobility testing. And this has been achieved in our group in Paris and now replicated also in Pittsburgh through 3 steps. 1 step on healthy volunteers, 1 step on patients that were the first testers, and then the validation that occurred over time to really validate at multiple levels, multiple experimental sessions, showing that 20 mazes were needed to avoid any learning effect, and 5 sessions of learning were good enough. And this is a demonstration of how consistent it is across multiple sessions, how it does reproduce in brown and in green what is in real life versus the maze in virtual reality, how it does correlate to multiple levels of testing, real life and virtual reality, how it does correlate with different types of tests like visual field, visual acuity, and these are different studies that were conducted, comparing, and this slide is very busy, but trying to analyze cone function using different methodology like the octopus, the Goldman, the cone rod breakout in dark adaptation with very good correlation. And based on that, we were able to develop this test, which is now showing a very good level of reproducibility that has been adopted for the natural history studies for Foundation Fighting Blindness, but also by several companies for clinical trials, and hoping it will be an approved endpoint. It's exported, it's got accepted, and patients say that it is reproducing what they are feeling in daily life. We also developed other tests, for example, central vision testing, object recognition, object detection. This is called VISA. People have to detect a cup or an object. Here, this is a very small, round, red object that we have to detect. And this has been also a very consistent test, which is now being standardized with the ability for patients to explore the room. And because we're dealing with very low vision patients, we developed a test for extremely low vision mobility. That is a physical test, but now also a virtual test that is reproducing what has been observed in daily life. So this is the work of many people, the team in Street Lab, especially the work of Paula Autier, but many others who I want to acknowledge. And we are now reproducing that and exporting that. And we believe that this type of testing, correlated with patient-reported outcome and the functional vision testing, has a future in any type of retinal and maybe ocular disease. Thank you very much. And now I'm very pleased to hand back to Dr. Garner.
Thank you very much, Dr. Sahel. And now we have Dr. Jason McNanny, who is going to talk about mechanistic insights from visual function testing in diabetic retinal disease.
Well, thank you, Dr. Gardner, for the introduction. So today I'm going to tell you about mechanistic insights that we've gained from visual function testing in diabetic retinal disease, or DRD. So as a bit of background, there's now mounting evidence of neural dysfunction that can precede the clinically apparent vascular changes in DRD. And it's now thought that diabetes impairs the neurovascular unit. In the clinic, we have several approaches that are available to assess vascular abnormalities, but approaches to quantify neural abnormalities are not as well established. So this has been a major interest of our group, and we've been very interested in using non-invasive methods to assess visual function in DRD. And the approaches that we've used can be loosely grouped into three different categories. So we have electrophysiological measures. These include the full field ERG, which I'll tell you more about in a moment, the multifocal ERG, and the visually evoked potential, or VEP. The ERG measures target the retina, so we can localize any disease or abnormality to the retina itself. The visually evoked potential requires both retinal processing and cortical processing. We've also been interested in pupillometric measures. The pupil measures require both retinal processing and also subcortical processing. And finally, we have psychophysical measures. These measures assess function throughout the entire visual pathway, from the photoreceptors all the way through cortex, and they require a behavioral response. So these include visual acuity, contrast sensitivity, visual field perimetry, color vision, dark adaptation, among others. So you may be familiar with these types of measures. So given the limited amount of time I have today, I'm going to focus on two measures, just to give you an example of how we can use non-invasive techniques to better understand visual function in DRD. So I'll tell you a little bit about the full field ERG and also about contrast sensitivity. So that we're all on the same page, I'll first describe what an electroretinogram, or ERG, is. So the ERG is an electrical response that's generated by the retina in response to flashing or flickering light. So to record this response, we use a fine fiber electrode that lays along the lower eyelid in contact with the cornea. The patient looks into a large dome that looks like this below, and the patient then can see a flashing or flickering light that looks something like this. The response of the ERG looks like this waveform. So what I'm showing you here is the voltage, or the change in amplitude over time that's elicited by the retina in response to this flickering light. So what I'm showing you here is a response from a large group of visually normal, healthy control subjects. And you can see that every time there's a flash of light, both a trough and a peak are generated. If we have 62 flashes of light in a second, then we'll have 62 responses in a second. So you can compare this healthy, normal response to that of two different diabetic groups. So I'm showing you in green a group of diabetics who have no clinically apparent retinopathy, and a second group of diabetics who have mild non-proliferative diabetic retinopathy. And you can see that the amplitude, or the size of this response, is about half of the control group. And again, we can measure this now from the trough to the peak to give us an amplitude. In this slide, I'm plotting the amplitude of that ERG, so how large was the response, across many different temporal frequencies, from very slow flicker over here around 10 hertz to very fast flicker over here around 100 hertz. And there are two aspects of this plot that I'd like to point out. The first is that at high flicker frequencies, the control group, shown in black, have a larger response than the two diabetic groups. In fact, the diabetics with no clinically apparent retinopathy have about a 40% reduction in their amplitude, shown here. And that diabetics who have mild NPDR are even more affected. They have about a 60% loss of amplitude. And you can compare this with the responses that we found at lower flicker frequencies for slower flicker. So at slower flicker, there are only minimal differences among the three groups. And in fact, they're almost identical for 10, 15 hertz. So what we're finding is that there's a selective loss of high frequency flicker in diabetics. So what can we do with this information? Well, I think this might be useful for better staging DRD. And I'll show you what I mean. So this is our standard way of thinking about diabetic retinopathy. We usually classify these patients according to the retinopathy stage from no DR, mild, moderate, severe, or proliferative disease. We also consider the extent of diabetic macular edema running this way. So in the data set that I showed you, there were 20 patients who had no clinically apparent retinopathy, clustering here, and 20 patients who had mild NPDR, clustering here. So by and large, these are very similar patients. There are not marked differences among these individuals. Now I can add another axis to this plot. And this axis represents their extent of neural dysfunction that we quantified from the flicker ERG that I showed you a moment ago. So now you can see that despite their very similar clinical characteristics, these patients vary tremendously in terms of their neural dysfunction. Some of them are perfectly normal, falling in this range. Others are 2, 3, maybe even 5 standard deviations below our normal range. So we can use the flicker ERG perhaps to better stage DRD. The one major limitation of the ERG is that it only tells us about retinal function. It doesn't tell us what the patient sees or experiences. And because of this, the FDA has been somewhat reluctant to use the full field ERG as a primary outcome measure in clinical trials. So to address this concern, we've begun measuring psychophysical flicker sensitivity in DRD. So to do this, we developed a novel visual field perimeter, which functions much like a normal Humphrey field perimeter, except that the light flickers on and off at a given rate in the back. So here's an example. So if this light in the back will begin to flicker on and off. Hopefully you can see that. And we can change the intensity of this flickering light. We can make either more visible or less visible, which allows us to measure a threshold. And in fact, that's what I'm showing you here to the right. So this is a contrast threshold for our control group in black, and then for our diabetic group in red. And you can see that when the light is flickering relatively slowly, there are only minimal differences between these two groups. Now, if we flick the light more rapidly, you see that there's a difference that begins to emerge, where the diabetics have less sensitivity to the flickering light than the normal controls. At our highest flicker frequencies, we find there's about a 28% loss of flicker sensitivity for the diabetic group compared to the controls. And if you look at this curve, you'll see that this looks very similar to what I showed you a moment ago for the ERG, where there are only small differences at low frequencies and larger differences at high frequencies. And in fact, we can correlate these. So we can take our ERG response and we can correlate that with our psychophysical response. So each of these dots represents a different patient. And you can see there's an excellent correlation between the ERG sensitivity and the flicker sensitivity from the psychophysical measures. So what this is telling us is that diabetics often do not perceive flicker as well as visually normal controls. And we think that this abnormality might be arising at the retina itself, perhaps within the cone photoreceptors. So to conclude, this is just one example of how we can use a non-invasive measure to learn more about neural dysfunction in DRD. And the flicker data that I showed you provides some mechanistic insights into neural dysfunction in these individuals. The selective loss at high frequencies we think is consistent with a cone sensitivity loss. An assessment of neural function might provide a better basis for understanding disease mechanisms and for perhaps classifying DRD. So thank you for your attention, and I'll turn it over to Dr. Gardner again.
Thank you very much, Dr. McEnany. And now, Dr. Lewis Lesmes will discuss contrast sensitivity testing in DRD.
Thank you, Tom. And thank you to the meeting committee for the opportunity to speak today about contrast sensitivity function in diabetic retinal disease. I'm especially happy for the chance to contribute to this panel led by Tom Gardner and to speak alongside such respected colleagues as Jose Alain Sahel and Jason McEnany. Thank you to Jenny Sun for this representation of diabetic retinal disease and how it highlights the need for an updated staging system. If we consider the trajectory of disease in this multidimensional space, from the upper left to the bottom right, we can see the trajectory from the good outcomes that are possible with systemic health to the poor outcomes that are realized with the worsening of neural, vascular, and biochemical function. In a new staging system, it will be critical to recognize how these multidimensional variables interact to contribute to the worsening of visual function and the deep reduction of quality of life that can occur for people with diabetes. I'd like to highlight some parallel efforts by the Ryan Initiative, led by Vas Sada, specifically their efforts to update the staging of age-related macular degeneration. In this report, they conceive of phenotypes of retinal disease as multidimensional data clouds with both non-modifiable and modifiable risk factors. Their proposal is to study the longitudinal flow of these data clouds, to evaluate how they may move over time, and to use that information about disease to improve drug development in AMD. But to return to the Mary Tyler Moore Vision Initiative and the Visual Function Working Group led by Adam Glassman, we can think of their job as zooming in on this dimension of visual functions and trying to figure out the most interesting subspace needed to quantify vision loss across the stages of diabetic retinal disease. In one example, imagine that a focus on this visual function axis is followed by zooming out on variables like the mobility testing presented by Jose Alain, or the electrophysiology presented by Jason, or the contrast sensitivity function that I will discuss today. The working group noted that because BCVA is affected only late in the disease, that one primary task was to rank other endpoints with the potential to quantify vision loss across all disease stages. Contrast sensitivity function emerged as one candidate, but over the next 5 years, more evidence generation is needed to make it viable as a registration endpoint for diabetic retinal disease. So let's talk about how we measure contrast sensitivity. This map of visual patterns, defined by the two critical dimensions of size and contrast, is the foundation of our assessment of contrast sensitivity function, which is the two-dimensional boundary that separates patterns that are visible and those that are invisible. On the right of this map, visual patterns are small. On the left, they are large. On the bottom, they are high contrast and are easy to see. And at the top of the map, they are low contrast, difficult, and sometimes impossible to see. One hallmark of this function is that it peaks at intermediate sizes and sensitivity falls off both as the patterns get smaller and as they get bigger. How will we measure this map? And the answer is 3 letters at a time using active machine learning. When 3 letters are presented on the screen, the first is the easiest to see, the last is the hardest to see, and the one in between is in between. When the patient reads the letters, they're marked on the remote as correct or incorrect, and when that information is put back into the active machine learning algorithm, it comes up with 3 new test conditions, which is then followed by another 3 test conditions, and on and on. This threshold contour that is measured can be summarized by a few metrics. One is the area under the log CSF. The other is a low contrast VA. And to review on how these metrics have performed in diabetic retinal disease, we can see that in terms of signal and noise, that we have noise of 1.5 dB and signals of 2.5 and 5 dB for mild and moderate stages of NPDR. Also with importance for noise, we have a low patient burden. This means that with no chin rest and normal seating, testing can be done in 4 minutes. With 95% of the tests that we've done in diabetic retinopathy, which here are numbering near 1,600, 95% of those tests are between 3 and 7 minutes. I want to take another short digression to talk about the prominence of the contrast sensitivity function and how its shape is conserved across many vision and imaging systems. If we start with the results that were first presented by Cynthia Owsley in a Now Classic paper, we can see that the hallmark shape of the function, with a peak in the middle and a fall off on both sides, is conserved in birds, humans, cats, primates with induced amblyopia, across different neural stages, which include retinal ganglion cells, midbrain, and primary visual cortex, in functional brain imaging experiments, and also in deep neural networks that, when trained on an image set and later tested with gratings, show a contrast sensitivity functions that is shaped just like in humans. To return to what's needed for clinical trial endpoints, in a previous meeting of the Mary Tyler Moore Vision Initiative, Adam Glassman presented several criteria that are needed for clinical trial endpoints in DRD, such as the characteristics of measurement, correlation with disease, and reliability. I'm happy to report that when it comes to contrast sensitivity, we've shown strong correlations with quality of life and daily activities. We've shown sensitivity to disease stages, such as mild and moderate NPDR and DME. In addition to the work done by Jason McEnany, I want to acknowledge how much of this validation work was done by John Miller and the Retina Service at Mass Pioneer, who have evaluated how contrast sensitivity correlates with patient-reported outcomes, with vascular structure measured with OCTA, and then the normative and test-retest studies that demonstrate a favorable level of noise for the size of the signals we'll be measuring in diabetic retinal disease. In terms of evidence generation over the next 5 years, here is a roster of studies that will be evaluating the longitudinal patterns of contrast sensitivity during disease progression and treatment. We're especially excited for the prospects of the MAGIC study with Charlie Wyckoff and the Retina Consultants of Texas to compare contrast sensitivity with retinal non-perfusion metrics that are serving as the primary endpoint, in addition to protocols AR and AS that were designed to validate functional endpoints for diabetic retinopathy and diabetic macular edema. To summarize, diabetic retinal disease should be evaluated across multiple dimensions. Contrast sensitivity function is an important dimension for spatial vision that shows potential as a visual function endpoint. And lastly, ongoing studies will contribute to the knowledge that is needed to validate endpoints for registration trials. Thank you so much, Tom, for the invitation to speak to the committee and the panel today.
Thank you very much, Dr. Lesmus. And now we will have the panel discussion. Okay, thank you. Those were three fantastic talks. Jose, let's go back to you. The IRD field has really pioneered the section out of cone and rod-mediated pathways, and that dimension hasn't really been so much a focus for DRD. What can we learn from you folks about the importance of understanding how the different parts of the retina are affected at different times?
Well, I think it's an important question, but really what matters most is really the pathway globally, not only at the cone or rod level, because it's really the two are so much converging at some point. And as you know, a lot of the changes are mostly occurring in the inner retina, and this is really how the information is being processed at that level. I remember when I was much younger, and I think you were also much younger, the work of Bresnik about the changes that he could observe with the techniques that were available at that time to look at the inner retina. I think we should view, and this is the beauty of the panel and the beauty of the approach that the MTM initiative is taking. We should look at vision as a global concept, and this is why vision for action or vision for mobility, vision for eye-hand coordination is so important. And where cones and roads do matter is really the daily situation that patients are living in. Patients don't care about roads and cones. They care about daylight. They care about central vision. They care about color vision. They care about dark adaptation and living and mobility in the difficult environment. So this is where I think we should focus. And actually, the last presentation, it's interesting to see the attempt to correlate the PROs and the contrast sensitivity. What we should have is really a multi-scale approach where we try to correlate all these metrics and to see which ones are relevant for daily activities. But keeping in mind the patient perspective, what is impacting their quality of life mostly, knowing that we don't have the right tools yet to measure quality of life.
Right. Thank you. That's a great question, or a great response. Dr. Pardue asked the question of Jason about the cellular origins of the higher flicker rate changes in DRD.
So I think these changes are mostly arising within the cone photoreceptors themselves. And the ERG that I was showing you actually is a measure of bipolar cell function. But of course, this is being fed upstream by the cones themselves. So what we can do is we can look at the cones and we can correlate cone function directly with some of these measures that I've shown you. And in fact, changes in the cones themselves are pretty good predictors of the flicker abnormalities that I showed you a moment ago. So of course, we're measuring the cones and then the bipolar cells with the test that I showed you previously.
So you said, I believe, that a subset of your patients exhibited the depressed flicker response, but they all had seemingly similar degrees of diabetes or retinopathy. Can you explain what might be underlying the subset of patients?
That's a great question, and we wish we had the answer for that. So we've taken these results that I showed you, and we've looked back in the charts to see if we can find if any of these measures that we measured, say, several years ago, turn out to predict any disease progression. And in fact, there's pretty decent sensitivity and specificity for the ERG test to predict in the future advancing in the NPDR stage. Mm-hmm. So I don't know what's going on at the baseline when we actually made the measures as far as their disease characteristics. They're all very homogeneous. But we know that it can, to some extent, predict future disease progression. But we think that the neural changes and the vascular changes may not necessarily be perfectly correlated. So they might proceed at different rates. So maybe that explains why some patients can be abnormal early on versus other patients who have early abnormalities in neural function.
But these patients were similar in terms of their diabetes control and duration?
Yep. Otherwise, they're similar ages, yep, exactly.
Good. Any overlap between what the flicker response and the QCSF data are showing, Lou and Jason?
That's a great question. And I think that's why at the last ARVO, Jason and I had the conversations about what we needed to do to get one of our machines into his clinic and to start collecting this data together. So that's going to be, I think, one of the exciting, offshoots of the consortium and some of these collective efforts.
So if the abnormalities are in fact arising early in the retina, maybe at the cones themselves, then it should affect flicker sensitivity, as I showed you, but also it should affect the letter contrast sensitivity that Lou had shown you as well. So these things all may be related in some way.
Fantastic. Well, that's great. Jenny Sun is asking Lou if he would talk more about the QCSF being used as a primary endpoint in the ONL study.
Right.
Are
so
here for that development for DRD. Maybe you can explain what the ONL study is to.
Right. So ONL Therapeutics had a neuroprotective therapy. The hope was that during retinal detachment, it could keep the RPE protective until there was a reattachment surgery. And you'll forgive me, Tom, when we get into surgical questions, this is where we really reach the limits of my training and knowledge and all these things together. But the takeaway, I think that was interesting was the opportunity to collect, contrast sensitivity along multiple dimensions. And so that is to say, not only normal luminance, but also low luminance, right? Not only in the treated surgical eye, but also in the fellow eye, to get really, I think, right, a landscape of visual function. And I think the very interesting opportunity in in the end, there wasn't the treatment effect observed that we had hoped, but we collected a very good data set. And I think it gives us a good idea about kind of not only contrast sensitivity, but kind of dark adaptation and the differences that happen between low and normal luminance. And these are all things I think that we know are very important to the patient experience. It was always very moving when Dr. Levine talked about Mary Tyler Moore and her troubles in, let's say, low light and mobility. And I think these things connect very well with Jose Allen's work. So I really look forward to getting, I think, all of these devices and all of these technologies together to try to figure out that clustering of visual deficits that we know is probably vexing these people with diabetes very much.
Right. Well, that's a great way of synthesizing all the comments and the biology, which is complex. And with all that in mind, do you think that the current approach we have for protocols AR and AS will be able to put that information together?
I guess what I'm finding very exciting is the idea that, right, high contrast visual acuity might serve let's say some anterior segment kind of applications more. But when it comes to retina and retinal disease, low contrast testing, right, whether it be like contrast sensitivity or low contrast acuity, low luminance, low contrast acuity, these are kind of start to get these multidimensional approaches that might help reveal kind of these hidden signals. So we do have, and then I guess the very exciting thing about those protocols is the longitudinal aspect, measuring the treatment effect in DME. And again, the idea that we'll be able to bring some of these devices together, like the objective field analyzer, like the RET eval that Dr. McEnany has done so much work on. I think it really is time to build on that multidimensional profile that we saw and again, see how that matters to how people move and how they function, feel, and survive, right? That's kind of, in the end, what the goal is.
Right. Well, that's why Robert has called this the DRD Cure Accelerator, not just the data collection accelerator. And, so, and our goal is to get to develop biomarkers or that will lead to regulatory acceptance for doing clinical trials, which is always the rate limiting step. Robert, I see you're here. Do you have any comments at the moment? Or Amanda?
All right. Thanks, Tom, for the invitation. No, I'm just I'm listening to this extraordinarily fascinating discussion. I think that we'll pick up some of the conversation in the next session. But thank you for inviting me. I think that I've learned a great deal, today, and I think that this, as Jose has said, as Louis has said, and Jason as well in this session, it's kind of the juxtaposition. It's the holistic view of these functional structural deficits that are really going to give us a true insight as to who are the proper candidates for intervention and how we can best select patients for clinical studies, as well as define, the delta, the efficacy signals that we need to have in order to really bring, new therapeutics to market that have disease modifying effect.
Yeah. So maybe coming from this can be sort of a synthesis and gradient of different types of information that can be collected in over time and over disease severity. Quentin Davis, not surprisingly, has a question for Jason. And he's saying, I don't understand why flicker-based sensitivity would be related to spatial contrast sensitivity. One is time-based, the other is not time-based.
It's a good question. So in fact, yeah. So actually, both these are time-based. That was maybe hard to see from the video. But what we're measuring is temporal flicker sensitivity, which is very distinct from your standard Humphrey visual field. So what we're measuring is the fastest flicker rate that a person can perceive. And that's much more analogous to the flicker ERG that I showed you at the beginning, when it gives with a flickering light. So in that way, they are parallel. At least that was the intent.
Okay. Does that answer your question, Quentin? Lou or Jose, do you have any other comments you'd like to make?
No, very grateful to put focus on function. It's a very important aspect and sometimes overlooked. So a very, very interesting panel, and look forward to collaborations on these questions.
Right. And then extending it actually to real world patient function, like Amanda's working on. Chris German, I see you're on. Do you have any comment or question?
Not at this time, no.
Okay. Well, speaking of a patient, Chris has long-standing type 1, if you don't mind my saying that, and is a very important part of the leadership of MTM Vision Initiative. Okay, we still have a couple minutes left, but I think we'll go ahead and transition to session 4, validating novel clinical endpoints that Robert's going to lead. Thank you all very much.
Thanks so much.
Thanks, Tom.
Thank you, Tom, Jose, Jason, and Lou for that important discussion. In our session 4, we hope to engage participants in a dynamic exchange regarding how to choose and validate novel clinical outcome assessments. Though I know most of you know these definitions, to level set our discussion, the FDA defines a clinical outcome assessment, or COA, as an instrument used to describe or reflect how a person feels, functions, or survives, and can be reported by a healthcare provider, a patient, a non-clinical observer, or through performance of an activity or task. There are, therefore, 4 types of COAs: patient-reported outcomes, clinician-reported outcomes, observer-reported outcomes, and performance outcomes. As I noted in my opening remarks for this virtual workshop, it is critical that we seek the perspectives of people with diabetes and DRD and find ways to better understand the social, emotional, and functional impacts. Listening to patients and understanding how their lives are changed by diabetes and DRD, their fears of vision loss, their treatment preferences and concerns, as well as uncovering the individual subtleties of functional impairment and trade-offs with treatment effects is essential to research success, new treatment adoption, and delivery of improved outcomes. In order to set the stage for our discussion on COAs, our session 4 presenters, Olivia Meyerhofer and Amanda Bickett, will share findings from data they have generated regarding patient priorities and concerns and through observation of performance of a well-defined task, respectively. Olivia will start us off. She is a global value lead at Boehringer Ingelheim, where her focus within the eye health organization is on diabetic retinopathy, with the ultimate goal of driving the development and commercialization of innovative treatments. Her areas of emphasis include documenting unmet needs, assessing the treatment landscape across geographies, and capturing the patient voice regarding their experience, journey, and pain points to gain greater understanding on how to best address their needs. In her presentation, Olivia will share some of the key insights collected through her recent market research highlighting current treatment patterns and perceived symptoms by disease stage, and priorities and concerns from patients with diabetic retinopathy. Olivia?
Thank you, Dr. Levine. It's a pleasure for me to be with you today and to share with you the results of this international market research on diabetic retinopathy, where we try to uncover what are the current treatment patterns across several geographies, how patient symptoms present, and what are the priorities and concerns from this patient population. So let's dig into the data, the study objective and the methodology. It was done in 2 parts. Part 1 was surveying healthcare professionals, so treating physicians that actually manage diabetic retinopathy. There are 2 parts to this first section, a qualitative part with long interviews and a quantitative part with a bigger number of retinal specialists surveyed through online methodology. And then part 2 was a patient qualitative research where we try to understand patient perceptions and their understanding of diabetic retinopathy, as well as the challenges that they face. So let's start with part 1 and a bit more on the methodology of the research. So as mentioned, there are two parts to it. The qualitative part was with 79 physicians across 5 different markets with interviews between 75 and 90 minutes, qualitative interviews. And then the quantitative section of the survey was an online survey of 40 minutes for physicians to fill, as well as 4 patient record forms that they had to document, which is a total of 1,300 patient record form documented. And of course, all these physicians had to be treating physicians with a minimum number of DR patients per month and personally responsible for the care of these patients. And we had several research objectives. How do they manage those patients? What is the visual impairment of this patient population? And what are the remaining unmet medical needs based on physicians' inputs? So starting with the unmet needs that physicians expressed, the top unmet needs, of course, relate to improved iteration of existing treatments. So, of course, they would want to see treatment that lasts longer or that are less invasive, so different routes of administration. But among the top 10 that you see here, you see the need for treatment that would have an ability to really stop the progression of the disease, and innovation that would be more suitable for patients that don't have complications of DR, but would benefit from a proactive treatment approach. And that would be, of course, also an alternative to laser for many of those patients that get PRP laser and that don't have DME. Interesting 2 quotes here from physicians that really convey the feel for this healthcare professional. The first quote is, "Today we are waiting for disaster to strike." And the second one, "We are limited in what we can do. We cannot affect prognosis." So it tells you a lot in terms of how physicians feel and what remains to be addressed and the level of unmet need in this patient population. Now, looking at how they handle their patient population in moderate NPDR patient without complication, the standard of care remains watch and wait, so no treatment because there are no good options today for this patient population. So still very much reactive and observing this patient population until something appropriate comes along to treat these patients. And then this is for moderate NPDR patients. For severe NPDR patients, you see in the US and in the UK, again, watch and wait being more standard of care for now. And in other countries like Germany, Japan, and China, PRP laser is used in a significant portion of the population to prevent further vision threatening complications. So not a lot of options for these physicians to choose from, really. Now we've asked them also to look at patient records form again, as mentioned earlier. So on the left side, you see the kind of symptoms that patients experience and that they report. And interestingly, even moderate patients report symptoms related to reading difficulties, contrast sensitivity issues, visual field deficits that are already impacting their quality of life. And it's also even stronger in severe NPDR patients. This is an interesting finding because there is a general perception that this patient population could be asymptomatic because their visual acuity is not impacted, yet you can see already that other elements of vision are already impacted. In addition to that, I want to wrap this first section up with the healthcare professional survey. And key message are really that watch and wait remains the standard of care for this patient population, even in more advanced stages of the disease when there is no complication. There are very limited treatment options today for these patients. Sometimes laser is used, but anti-VEGF is used in a very limited number of cases when there is no edema. And then, interestingly, patients, even already at moderate and severe stages, do report already some visual impairments, which is going to be further documented by the protocol AR. We are really looking forward to this work. Now moving to the patient section of this research. So this was more a qualitative analysis where we interviewed 17 patients with 60 minutes interviews, and they also had some homework to perform. Patients were selected from a spectrum of the disease, from moderate stages all the way to proliferative stages, and we tried to understand what they know about their disease, how they felt, and what were the key pain points. So all in all, it's interesting to see that they know about their disease, but not a lot. They just know it's a consequence of their diabetes and that is progressive. That's really it. The next element that comes up is the fact that they are aware that there are treatment options, that they are invasive and unpleasant, and they all experience symptoms. So even these earlier patients that we described also reported some symptoms back, which they need to manage together with their other comorbidities. They all live in a climate of fear and anxiety, the long-term fear of vision loss and the short-term fear of invasive treatments. And interestingly, they were all willing to accept preventative treatment should that prevent further vision loss, which is not always what the scientific community would think, that they might not be very willing to undergo a preventative treatment. But apparently, if they understand what's at stake, they would definitely be happy to do so. Now, what's still very much unclear to them is how the disease progresses. So this is not always discussed. And ultimately, they don't understand the specificities of the progression, the timing, which adds, of course, to the uncertainty in how they feel. And they do understand that managing their diabetes could help limit the progression of their diabetic retinopathy, but yet they are still absolutely unsure what timeline we are talking about here. So limited education and awareness on that. Moving on to what other barriers exist. So they generally lack the understanding, as mentioned, of how and when the disease will progress. They think that the current treatment could definitely address their disease progression, so they're counting on that. And then there is the element of present bias that is very strong here, which is the bias of the fear of what could happen immediately to them. So invasive treatment versus the fear of what's more distant, which is the fear of losing vision. And all of that adds up to a limited urgency to act and really be empowered in managing their disease. All in all, it's fair to say that they would be willing to accept an IVT preventative treatment, but that will, of course, depend on the physician's ability to really communicate the benefits of preventing disease progression. So to summarize this last section on the patient survey, this patient really live in fear and anxiety regardless of the stage of their disease. They don't know how, they don't know when, they don't know how quickly it will progress, but they understand that the disease is definitely challenging their quality of life and creating this uncertainty. They all have symptoms, apparently, even at earlier stages, and in general, they are happy with the idea of preventing further vision loss with the support of their physician, of course, with the right level of education. So that concludes my presentation, and now back to you, Dr. Levine.
Thank you, Olivia. Our next presenter is Dr. Amanda Bickett. Amanda is an ophthalmologist on the faculty of the University of Michigan's Kellogg Eye Center, where she directs the Glaucoma Fellowship. Her research centers on patient experiences and functional outcomes of chronic eye disease and its treatments. She holds a joint appointment in the Department of Biomedical Engineering, and most recently has turned her focus to studies of gait and mobility in visual impairment using wearable sensors. In her talk today, Amanda will discuss the power and promise of GAIT as a patient-derived performance outcome endpoint, learnings from her GAIT research in glaucoma patients, and her currently enrolling study of GAIT in diabetic retinal disease. Amanda?
Thank you, Dr. Levine. You've heard today from an incredible lineup of distinguished speakers about structural, cellular, and molecular approaches to measuring outcomes in diabetic retinal disease, and about sophisticated functional testing. Olivia's great talk reminds us that the patients often experience impairment from their diabetes-related eye disease in the mundane essentials of daily life. What if we could follow them into their daily lives to see the impact of DRD and its treatments? I hope to convince you that we can, and we should. First, the why. I think we can agree that a core aspect of the clinical benefit of any therapy is its impact on a patient's daily function. But daily function can be difficult to quantify. Sometimes we use surveys, otherwise known as patient-reported outcome measures, but these can be susceptible to subjective bias. And while they can be highly reproducible, in-clinic or in-laboratory measurements do not assess function in daily life. Wearable devices that can function within but also leave the lab or clinic are able to directly measure things like sleep, levels of physical activity, and walking. In other words, they allow us to collect data directly on how patients function in their daily lives. And of course, when we talk about endpoints, we're talking about trials. So an important driver of this approach is its acceptability to regulators. This published FDA guidance, which is now more than 8 years old, spells out why endpoints proving functional benefit are critical, using the example of Alzheimer's disease, in which the endpoint of cognition can be most meaningfully understood in the context of a clinically interpretable measure of function, like a validated assessment of activities of daily life. There's also peer pressure. In other fields of medicine, use of wearables to generate patient-derived outcome data has been on the rise for a decade. Though the majority of these outcomes are still considered exploratory endpoints by clinical trialists. So we want to measure patient-derived endpoints in a way that reflects real-world daily function in patients with diabetic retinal disease. Why measure GAIT? In part because we already know it's important. Walking speed has been called by some the sixth vital sign. To justify that designation, I'd like to share this figure. It's from a review article that was published 10 years ago, but it brings together a decade of functional research, and its findings are striking. The average walking speed of those who can safely cross the street independently highlights the mobility challenges that we all face in daily life, and the fact that losing the ability to carry your groceries or do light yard work may be associated with cognitive decline in the next 5 years is fascinating. GAIT is not only important, it is complex, and it's thus rich in nuanced information. This image from my collaborator, Laura Ojeda, shows what traces from a wearable inertial measurement unit, or IMU, on the dorsal surface of the foot might look like, and how these can be used to recreate the motion of that foot. We can look not only at pace, but at symmetry or smoothness, and at variability of gait. And we can capture gait with wearables in just about any environment, in a gait garden, in a virtual reality environment, as you heard described earlier, or even in the wilds of a patient's home environment. Finally, and of paramount importance to this group, gait is impacted by eye disease in characteristic ways. I'm a glaucoma specialist by training, so my interest in gait started with an interest in the ways eye disease affected my patients' mobility. Data from the National Health and Nutrition Examination Survey showed that increasing visual field loss was associated with reduced physical activity. And in our own work, we've shown that glaucoma patients for whom loss of contrast sensitivity is an important, if often undermeasured, disease feature, not only walk differently, but cannot adapt their walking to changes in the visual environment, like lighting. Here, I've highlighted a pattern that we saw across both pace metrics and variability metrics. Glaucoma patients showed not only more cautious and variable gait overall, but got slower and more variable in dim light, and more interestingly, did not recover their baseline gait when the lights came back on. Crucially, these changes were evident across the whole spectrum of disease, visual severity, field loss, which is to say from the earliest minimally symptomatic stages of glaucoma. I actually stopped turning off the lights in my exam room for most patients when I saw these results. So now back to diabetic retinal disease. Working from the assumption that microvascular and neurodegenerative changes reduce contrast sensitivity and impact visual field even before diabetic retinal disease is clinically evident, we can expect that gait is impacted by diabetic retinal disease. One of the Mary Tyler Moore Vision Initiative working groups identified visual function tests that might serve as biomarkers in diabetic retinal disease, and importantly noted that both visual acuity in low luminance and contrast sensitivity suggests risk of impairment, and that both contrast sensitivity and visual field are prognostic measures in this patient group. I think we can measure the sixth vital sign, gait, to take advantage of this. First, though, we should mention that we expect gait data in diabetic retinal disease to be influenced by the complex ways diabetes affects the nervous system. In those with diabetic retinal disease, in addition to loss of visual field and contrast sensitivity, diabetic peripheral neuropathy may lead to altered biomechanics and poor sensory feedback, and diabetic autonomic neuropathy may impair balance and increase risk of falls. But while this may make it more complex, it also makes it all the more important to understand the multifactorial motor impairment that comes with diabetes. To begin untangling gait in diabetic retinal disease, we're conducting a study similar to the one I described in glaucoma in patients in a cohort with diabetes, examining gait responses to changing lighting conditions while controlling for diabetic peripheral neuropathy. Since I shared these plans at the November symposium, our team has been fortunate to be awarded funding from the Michigan Diabetes Research Center. Participant enrollment for this study began last month. Finally, to bring us back to our goal of capturing gait endpoints in the real world, I want to share a few figures from our recently completed study comparing in-clinic and real-world gait quality in older adults with glaucoma. This work was completed in collaboration with the University of Pittsburgh and funded by the NIA's Older Americans Independence Centers. We first captured gait metrics in clinic, then trained patients to put on and take off IMUs at home. Over 3 days, they captured 24 hours of free walking data. Among our findings was the fact that the length and speed of steps taken at home and in clinic were clearly associated, but the variability of at-home gait was not associated with in-clinic variability and was often greater, suggesting that testing in clinic may miss the influence of environmental factors on gait. We included in our study of glaucoma patients a patient-reported outcome measure, the Glaucoma Activity Limitation Questionnaire, to explore whether and how patients' self-reported impairment related to changes in their gait. Interestingly, patients with slower gait speeds and more temporal variability in their gait seemed aware of functional limitations, but those with less symmetric or spatially variable gait did not. These results lend weight to the idea that patient-reported outcome measures cannot tell the whole story of real-world function. We have to find ways to join patients in the real world. Again, I'm a clinician, so I want to pursue real-world gait assessment because it may help me and my colleagues guide our patients toward their most functional, independent, fulfilling lives, and because they may help us find clinically meaningful impairment in function even before vision metrics in diabetic retinal disease change. But we are here today to discuss the even broader potential for gait assessment to inform clinical trials. Regulators tell us a primary endpoint for determining that a drug is effective should encompass important features of a disorder and should be clinically meaningful. The structural, cellular, molecular, and even functional endpoints you've heard about today can certainly accomplish the former. Real-world gait endpoints may help us succeed in proving the latter. We'll answer questions in the live session. Now I'll turn it back over to Dr. Levine.
Thank you, Amanda. Let's now shift to our discussion and Q&A. I asked two members of the Mary Tyler Moore Vision Initiative's lay advisory, Adriana Plevniak and Chris German, to join our presenters on our panel. Both Adriana and Chris were diagnosed with type 1 diabetes as young children, with Adriana having experienced vision-threatening DRD during a pregnancy, with a significant iatrogenic adverse event occurring in the context of her laser photocoagulation treatment. And Chris, thus far, not being challenged by vision loss, but is practicing what we used to call watchful expectancy, which is of course, not without its own impacts on sense of well-being. But for the first question, let me ask Olivia, what surprised you? Because I was surprised by some of your findings. So what surprised you most about your findings? And based on these observations, what do you think needs to happen to progress the field?
Yes, thank you for the question, Robert. So I think what surprised me is being proven wrong on many fronts. And I think when we do this kind of work, we need to be ready to be challenged in our belief system. And what I mean by that is that we walked in thinking that these earlier patients were asymptomatic, which is what we had heard. And the finding shows that even at earlier stages, these patients are already raising concerns in terms of visual impairments. They talk about, and this connects very well with the previous talk, right? The contrast sensitivity, the ability to read, night vision for some of them. So, these findings now correlate with the most recent science, but walking in, we did not expect that to come back. And it's completely aligned, of course, with the recent findings. And the other belief that we walked in with was that patient would not be willing to consider preventative treatment, if that doesn't improve their vision, intervention before actual vision impact happens. And we were again proven wrong. And we had a very progressive mindset from patients thinking that they would be willing to intervene at those stages before damages happen. So they understand the concept and the benefit of preventing progression rather than waiting for those damages to happen. So that was also a surprise for us. And what it means for us is that, we are thinking about this disease in a very reactive way today. We really wait for damages to happen to intervene. And that means that a shift in paradigm needs to happen, and we need to think about offering alternative options to these patients and moving away from this firefighting mindset of reacting to how the disease progresses, but rather being more proactive in the treatment approach. That doesn't mean that every patient will be needed to be treated from the initial stages, but it's really finding the right patients at the right time to be treated, and offering more treatment options also is one of our focus, and more innovative pathway, which is what this group is working on in a very productive way. And this is why we are partner on this initiative. We strongly believe that this is what needs to happen in this field, and more treatment option, more innovative pathway, and an evolution in the disease classification, which is already underway. Of course, structure function correlation is very hard to do, and it's been a challenge in many fields in ophthalmology, but it will be essential. And for us, connecting retinal non-perfusion and making it really a clinically meaningful prognosis indicator will be very key.
Thanks, Olivia. I have a question from Quentin Davis. Quentin, I was going to frame it somewhat differently. First, to ask Adriana and Chris, maybe Chris first, because he hasn't reported symptoms. Ask him to respond to the point that Olivia made, that their research demonstrated a willingness on the part of individuals who are pre-symptomatic to accept preventive interventions if explained well.
Well, I think that finding reflects certainly my experience. And I think I can only speak for the type 1 diabetes community, but there's quite a prevalence in the community of wanting to have preventative measures and early intervention. And since I was diagnosed, I hear all the time and am constantly reminded by my endocrinologist of the onset of complications, right? And everything that we're doing now is to prevent the onset of those complications down the line. And so when you have a patient population that in many ways has been trained to that perspective, wanting to intervene early to prevent diabetic retinal disease, I guess to me isn't particularly surprising. And it falls completely in line with my experience, and I know the experience of many others.
Yeah, thanks, Chris. And Adriana, would you describe some of the spectrum of some of the symptoms that you've had, and the impact of current standard of care has had on your vision?
Sure. My symptoms, I think I've always had problems with contrast. So especially at night driving, the bright lights have bothered me since I remember them bothering me as a teenager. And everything, I would go to the ophthalmologist and my eyes were fine. But I think it started back then, and it's kind of progressed and gotten worse over the years. I have trouble reading. My depth perception is pretty off. So it's definitely had a huge impact on my life. And it's, the last 11 years have been very difficult because it has gotten so much worse. And there's a constant fear of, okay, what's going to happen next? It's going to get worse. And I like what Olivia talked about, the patients were saying, or the doctors were saying that they're reacting to everything instead of preventing. And that's, as a patient, you feel bad. I feel that I go to the doctor just waiting to see, okay, what are we going to do how are we going to react to what's happening in my eyes?
Thanks, Adriana. And go ahead, Chris, were you going to say something?
I was just going to say to the point that Adriana makes about prevention and intervention. One of the things that I was wondering about, and perhaps Amanda, you can speak to this, is in the course of disease progression, where does gait or where do you anticipate changes in gait show up? And how do those overlay to the observed changes in the neurovascular unit that previous presenters were discussing?
That's a great question. I wish I had a better answer, but I'll tell you what we've learned from my glaucoma patients and what I expect we might learn from our diabetic patients. Today we're testing participant number 7 in this pilot trial of these protocols in DRD. In glaucoma, similar to DRD, we sort of think of symptoms only beginning when a patient reaches moderate disease, or when they have visual field loss that's below a certain sensitivity level, a mean deviation on Humphrey visual field. And even when I talk about the work that I do with my colleagues here at Kellogg Eye Center, they'll often say, "Oh, but you mean for moderate patients?" What we found when we tested patients' gait in glaucoma was that from the earliest measurable visual field loss, which we would consider very mild disease, what we would understand as asymptomatic peripheral disease that we're catching before a patient has any change in their function, they're less responsive to changes in lighting. They're more, they don't recover their baseline gait as quickly when they're perturbed. So it isn't that those patients report to you that they are impaired, and it isn't that they walk differently or more slowly or less stably or with poorer balance or, differently across a threshold in ideal lighting conditions. But the way that Adriana described struggling with nighttime driving conditions, or situations that threaten or challenge your contrast sensitivity, people start responding to those, it seems like, almost immediately as soon as they have measurable visual field loss of any kind, of which there is plenty in diabetic retinopathy, diabetic eye disease, and that it's almost a smooth, it's sort of a smooth, continuous variable, that degradation in responsivity of gait to lighting change and to environmental change. And it's one of the reasons why we wonder how best we can intervene, whether there are training techniques that a person, whether Dr. Sahel showed us the Street Lab VR gate system. Can you teach a person to move safely in challenging environments when they are losing that ability so that they can keep it longer in a sort of conscious or intentional way? Because we think that gait change starts from the earliest measurable change in either visual field or contrast sensitivity, which, as we've heard today, are reflective of the neurovascular unit changing.
Yeah. So Olivia, I mean, this picking up on Amanda's note and your findings, the surprising findings about especially in terms of individuals who are characterized as having mild and moderate NPDR and yet still reporting symptoms. How are you at Boehringer Ingelheim integrating that new understanding into decision making, whether it's pipeline decision making or protocol development, decision making, patient selection, decision making? How do we now bring in that new understanding that patients are reporting symptoms even when they don't appear to have disease that we otherwise would characterize as treatable, and how do we now better evaluate those individuals, and can we use things like gait as part of that selection process?
That's a good question. And, we are staying very close to all these topics because everything is new information and we are progressing our pipeline, and we need to, of course, evolve and shift our focus based on all these new findings. So we are very interested in what's going to come out of the protocol AR because of evaluating all these new functional endpoints. And based on what we see coming out of that and all the work also happening in different places, including, of course, these gait assessments, we will make sure that the later stages of our clinical program include those very important endpoints, and we make sure that we are able to really put into our clinical development plan tangible patient outcome that can really measure clinically meaningful elements for patients, which is something we are very focused on, and we want to make sure that all our clinical trial program really embed this patient-focused element in the selection of endpoints that we include in our trials. So this is also why we are part of the collaboration here and very interested in staying very close to all this very exciting development that everybody is working on, because we will adjust and our clinical development program based on all these findings coming in.
Yes. Thanks, Olivia. We're looking at about a minute left. I just wanted to ask Amanda, and then I'd like to have Adriana and Chris close us out. You're using, as I understand it, a kind of research grade IMUs, sensors. How do we now move from use of kind of research material to this readily available, universally available wearables, that are out there, whether it's Apple Watches or otherwise, that can possibly give us some even larger data sets in terms of real world data collection?
Yeah, in 30 seconds or less.
Yeah, exactly.
We know that gait speed's important, and we know that levels of physical activity are important. And we're currently uncovering which aspects of more detailed gait metrics are key. And that will tell us how much we can glean from like a one location wearable. When we do sensor testing in the lab, usually a person's wearing at least 3 and sometimes 6 instruments. But there are things you can learn from a Fitbit or an Oura watch, or an Oura ring rather. Using commercially available wearables raises like data quality and data sharing challenges. But I think the first question is which questions are important, and then we can get to how do we gather data properly to answer them.
Thanks, Amanda. So we have no time left. So I'm going to give each of you, Adriana and Chris, 10 seconds to have a final word on this. Chris, go ahead, because Adriana gets the last word.
Fair enough. She's the one most affected by this. I just want to thank everybody for being here today and all the work that you're doing, and everything that I've heard in the sessions thus far. It sounds extremely promising that we'll have very meaningful endpoints coming soon, and that those can be very quickly integrated into clinical trials, and hopefully will lead to the development of preventative measures for my sake.
Thanks, Chris. Adriana?
I second everything Chris just said. I think as someone who is in the thick of this right now, it's very promising. And it's also promising to hear that this can be prevented so other people like Chris don't have to go through what I've had to go through.
Yeah. Thanks so much, Adriana. Thank you all very much. It was a very informative session, and I need to now transition ourselves to session 5, which will be led by Malvina Edelman, the CEO of the CCOI. Malvina.
Hello, I'm Malvina Edelman, CEO of the Collaborative Community on Ophthalmic Innovation, CCOI. We are proud to partner with Mary Tyler Moore Vision Initiative to launch the DRD Cure Accelerator. Mary Tyler Moore wasn't just an icon. She was a patient. Her story centers us. It reminds us exactly what this work is about: restoring vision, preserving independence, and delivering real impact for real people. At CCOI, we're not chasing abstract metrics. we're embedding the patient voice into every decision. Because if it doesn't improve lives, it isn't progress. With this partnership, we have a chance to transform the future of diabetic retinal disease, and we intend to do just that. CCOI is driven by a bold mission to remove every barrier standing between groundbreaking ophthalmic medical products and the patients who need them worldwide. We exist to accelerate the future of eye care. The DRD Cure Accelerator is one of CCOI's 17 working groups, each advancing a specific goal, all united in driving forward our shared mission. Breakthroughs in science and clinical research are only the beginning. For these innovations to actually benefit patients, they must be translated into safe, effective medical products, approved and accessible on the market, and delivered to patients. Without approved or cleared medical products, even the most promising science stays in the lab, and patients see no change in outcomes. The path to patient impact runs through innovation, development, regulation, and adoption. Regulation of medical products varies significantly across countries, and it results in different requirements with different data for demonstration of safety and effectiveness and different administrative procedures. What remains the same is that all national regulatory frameworks classify medical products into 4 fundamental categories: drugs, devices, biologics, and combination products. Medical products are essential at every step of DRD care continuum. We need them to screen, diagnose, assess progression of, and treat DRD. Medical products are also essential to enable clinical research and evaluation. In the United States, screening for DRD often occurs with teleretinal devices. However, currently, none have indications specific for DRD. We are incredibly fortunate that today in the United States, we have 3 AI machine learning devices for screening. Their indications for use are summarized on this slide. There are many devices on the market that are cleared to aid in diagnosis of DRD and ocular disease, such as OCT, OCTA, fundus photography, fluorescein angiography, ultrawide fundus photography, electrodiagnostic devices. However, currently, there are no medical products that are specifically approved or cleared for diagnosis of DRD. There are currently no FDA cleared or approved medical products specifically indicated for tracking DRD disease progression over time. Current practice relies on subjective interpretation, non-standardized imaging biomarkers, or clinical endpoints applied inconsistently due to lack of consensus. Lack of progression-specific tools slows clinical decision-making, impacts trial design, and hampers innovation. Currently, in the United States, between 2006 and 2025, 14 drugs received approval for DRD treatment. As far as devices, we have devices cleared for laser photocoagulation in diabetic retinopathy, as well as intraocular retinal photocoagulation as an adjunct to vitrectomy surgery. We do not currently have any biologics or any combination products on the market specific for DRD treatment. Well, why is it that we have such a significant DRD medical product deficit on the market? Current practice relies on subjective interpretation, non-standardized imaging biomarkers, or clinical endpoints applied inconsistently due to lack of consensus. There's a lack of progression-specific tools that is slowing down the clinical decision-making, impacting trial design, and hampering innovation. Medical products don't get to patients on science alone. They require a foundation of standards, guidance, and consensus. Standards outline preclinical testing and recommended clinical trials, and the FDA utilizes a recognition process to show which standard FDA recognized for use in satisfying a pre-market submission requirement. Guidance describes regulators' interpretation of or policy on a regulatory issue. Unfortunately, in the United States, the only guidance specific for diabetic retinopathy is a draft guidance from 2008. There are also no standards specific for DRD medical products, either at the US or international level. There are a number of relevant standards that I have summarized on the slide. However, once again, I want to emphasize that no standard specific for DRD medical products exists today. The goal for CCOI Cure Accelerator is to generate global consensus on endpoints and biomarkers for DRD diagnosis, risk prediction, progression, and treatment efficacy assessment. We are going to engage stakeholders through the CCOI Cure Accelerator to build agreement on clinically meaningful, scientifically sound endpoints that we then can translate into consensus and eventual standards. The standards will then be adopted by regulators worldwide and enable faster, harmonized approval of effective DRD medical product, and eventually reach our goal of accelerating access to innovation for patients worldwide. Step one in our process is listening to the ecosystem. To build meaningful endpoints, we need to start by surveying critical voices. We need to listen to patients and caregivers and ask them what outcomes matter most to them, what defines meaningful change in their daily life. We need to ask innovators and developers what's needed to translate discovery into approved products, and what are the current roadblocks in defining and validating endpoints. This input will anchor the process in real-world relevance and ensure that regulatory and commercial viability from the start. We are very excited to announce our partnership with NADA. Through AI-powered surveys, NADA captures stakeholder insights rapidly and with precision, ensuring that the voices of patients, clinicians, and innovators directly shape meaningful progress. NADA gives everyone a voice at scale. It enables instant digital focus groups for from 10 to 20,000 people, generating actionable insights in minutes instead of months, while reducing project costs, delivery times, and execution risk. It is a truly anonymous, safe space that allows for actionable, qualitative insights at scales. In other words, it will allow thousands of people to connect, ideate, and respond to key questions in minutes. It will capture millions of ideas and perspectives through real-time video conversations at scale. It will replace manual, time-consuming analysis with automated AI-driven dashboard and maximize diverse engagement by capturing the views of an entire population instead of just a selection. It will provide us same-day access with no need for integration or downloads. These sessions will require only 1 hour to complete the process, and it will allow us to instantly summarize and aggregate ideas and viewpoints inclusively and impartially. NADA's AI dashboard will summarize quantitative and qualitative inputs into key takeaways and themes, and it will filter and segment the data and download custom reports for our presentations and further discussions. NADA is ISO 27001 certified and vetted. I want to reemphasize that all data captured in NADA is anonymous. We will be working with NADA to co-design 2 sessions and handle setup with no heavy lifting required from anybody on the team. Once we finalize the details of these 2 sessions, we will communicate them to all of you and hope that you and all of the stakeholders that you're aware of will join us on this journey. Next, we will bring the data to the table. The survey results from patient caregivers and product developers will be analyzed and synthesized and presented at the next MTM workshop in November of 2025. This will help us to validate insight with broader stakeholders. After that, we will continue on a structured consensus building on DRD endpoints. We will incorporate the Aptus consensus meeting from Japan later this month, aimed to develop best practices for adopting AI-driven diabetic retinopathy screening, as well as our ongoing conversations and collaborations of all global stakeholders under the umbrella of DRD Cure Accelerator working group. The goal is to forge credible, widely supported endpoint recommendations to form the foundation for consensus documents and international standards. CCOI and MTM Vision Initiative, working together under the umbrella of DRD Cure Accelerator, will eradicate DRD-related vision loss worldwide. Thank you very much for your attention. Now I would like to continue with our session 5, Translation to Action. Next speaker will be Dr. Michael Abramov, who will talk on practical methods in identifying and validating endpoints and biomarkers for medical product development. He will be followed by Katie Capana, who is an Associate Office Director for Strategic Development, Office of Strategic Program and Technology Innovation at FDA. She will talk about FDA Home as a healthcare hub, CDRH initiative to enable healthier living. Subsequent to her presentation, we will continue to a panel discussion. And now, Michael Abramov.
Thank you, Dr. Edelman and Malvina. I will now make a brief points about practical matters in identifying and validating endpoints for diabetic retinal disease. So I want to start with that we really need an ethical foundation for endpoint development, and a lot of work on that had been done, and essentially we'll base them on these fundamental bioethical principles of beneficence, or first do no harm, autonomy for the patient, and justice, so that we can place patient outcomes central and not spend too much time in a patient-physician relationship. Also, it allows quantification how far any endpoint finds balance between these different bioethical principles, and that aids in creating support among all healthcare stakeholders, where this is about more than just satisfying regulators like FDA. We want to make sure that even payers all support the endpoints we are developing. What is an endpoint? It's a falsifiable test that essentially gives a patient benefit in some form. There's two types, really. There's clinical endpoints, where directly related to patient outcome, they're considered the most reliable. But especially in chronic disease, such endpoints may take years and sometimes decades to manifest, and that leads to unacceptable delays and costs for innovation, including new treatments and new drugs and new diagnostics for diabetic retinal disease. That's why in the past we've come up with surrogate endpoints. They should predict or correlate with a clinical endpoint, but then can be used as interim endpoints in clinical trials, so it can be faster and possibly at lower cost. For example, LDL serum level predicts myocardial infarct, and that has now been accepted as a surrogate endpoint in FDA trials. And it also means that the claims for that specific treatment says it improves LDL rather than directly reducing the incidence of MI. But we already know that lowering LDL reduces incidence of myocardial infarct. An example that was done, not in this context, for AI trials, and that we published a while ago, is reference standards and a metric for the quality of the reference standard, where the first one indeed reflects this association with clinical outcome, as you can see here. And as we go down the list, it becomes more about agreement and disagreement of clinicians and other experts in the form of reading centers and even individual clinicians. So you can again see this validation against clinical outcome as really being the ideal for a reference standard or for an endpoint. So surrogate endpoints need to show either evidence of prediction or correlation with a clinical outcome. And finally, if you do not have that evidence for prediction and correlation, it's considered a reasonably likely endpoint. And then before you can make it an endpoint sufficient for a clinical trial, typically it will require to creating that evidence in some form. And that's, of course, what we'll be focusing on in the next months, maybe years. I wanted to go through a few existing endpoints, especially in vision, and I will underline the ones that the FDA has already accepted as primary endpoints. I'm focusing on primary endpoints for clinical trials here, not so much on secondary outcomes. They're very interesting to discuss, but it would take too much time to explain all of that. So if you look at the endpoints, the primary ones for vision, for retina, have been functional primary endpoints: visual acuity, perimetry, meaning visual fields of some form, contrast sensitivity, and what is called a full-field stimulus threshold, especially for where patients already have lower visual acuities to measure improvements or at least stabilization. Also have been accepted as primary is patient-focused primary endpoints, and that includes the multi-luminance mobility test, which has been used for Luxturna as the first one, gene therapy, essentially a maze where patients have to navigate a maze. Also, patient-reported outcomes can be considered endpoints, but they have not yet been accepted as a primary by FDA. Functional surrogate endpoints, none of them primary today, that include blood flow, laser spectrography, electrophysiology, pupillometry, and color vision testing. So rather than the first list of functional endpoints that are accepted as primary, these are not yet considered as primary and can be considered surrogate if there's evidence that they indeed correlate to outcome. Then there are structural surrogate endpoints, including from fundus photographs, from OCT, from autofluorescence, and one of them has been accepted as the EDTRS, to my knowledge only one, the EDTRS scale for progression of diabetic retinopathy. has been accepted as a primary outcome. And then finally, there's a concept called composite endpoints, which are combinations of one or more of the above or new endpoints, where they become primary as a composite. And I think that's a really interesting avenue to consider. I want to end my presentation with thoughts about putative endpoints for DRD. On the left, you see the figure from one of the papers that started what we're working on, where essentially we said there's three axes: one for ischemic component of diabetic retinal disease or retinopathy, one for the neurodegenerative axis of diabetic retinal disease, neurodegeneration, and the final one for diabetic macular edema. And so you have three axes, and patients can be on different positions in this three-dimensional space. And for the ischemic component, we have accepted structural endpoint, which is the either trace progression. We can consider electrophysiology, and we have talked about it in the past. We have neurodegenerative component endpoints, and that is perimetry, and that is accepted for glaucoma trials. For the diabetic macular edema, of course, we have visual acuity as well as primary and accepted, as well as OCT biomarkers or surrogate. And then patients reported outcomes not yet primary to date. And all components together for advanced stages of disease, definitely MLMT or multiluminance mobility test, as well as full field stimulus threshold tests have been accepted as primary endpoints. The reason to bring it up in this way is that I think it's interesting or illustrative to look at endpoints that already have been accepted as primary and maybe work our way backwards to where we are currently, as well as working our way forwards from the science that has already been done toward endpoints that indeed either convey how the disease is behaving early on before symptoms develop or before irreplaceable damage has been done, as well as saving time on clinical trials going forward, because we all want ultimately people with diabetes to benefit from these new treatments that are hopefully safe and effective as soon as possible. And that's ultimately the goal for this discussion. I look very much forward to Dr. Edelman Malvina moderating our panel discussion and discussing some of these issues. Thank you very much.
Thank you, Michael, again for a terrific talk summarizing practical methods in identifying endpoints and biomarkers for medical product development. And now I'm delighted to introduce Katie Capana, who will talk about CDRH initiatives to enable healthier living as part of FDA's Home as a Healthcare Hub. Katie?
Thank you, Malvina, and thank you to all of the organizers for the very kind invitation to participate today. By way of background, I am a biomedical engineer. I had primarily 20 years of development and innovation and evaluation experience with a focus in cardiovascular devices, public health with a focus in clinical trials and other methods of evidence generation, as well as a healthcare MBA. I lead strategic initiatives for cross-cutting areas and serve as the executive sponsor for the Home as a Healthcare Hub, which I will speak to you about today. I will start by framing the need and the opportunity for this initiative, discuss some of the important roles that MedTech solutions play in improving health outcomes through this effort, and introduce you to our IDEA Lab. So briefly, the Home as a Healthcare Hub is our CDRH initiative to enable healthier living. We started by looking at our learnings and over a decade of strategic efforts to advance patient-centered medtech innovation and evaluation, working collaboratively with partners across the health ecosystem, such as this group and CCOI. This initiative is well aligned to support collective efforts to achieve better health outcomes for all. And it recognizes that the U.S. is facing an epidemic of chronic disease, aging population, an overwhelmed healthcare workforce and system, and rising costs of care that don't always add up to better health outcomes for patients. At the same time, the care delivery paradigms are shifting outside of hospitals and closer to the patient. This shift is driven by all of these factors, as well as the necessary adaptations and learnings from the COVID pandemic, innovations in technology and care delivery, and demands from patients and consumers. We see a need for better solutions that are intentionally designed to meet people's needs where they live, work, and play. So this initiative asks us, what happens when we zoom in on the patient if we seek to better understand their experience living with a health condition, a day in the life, so to speak, and imagine ways to improve their health and quality of life in a way that fits into their lives more seamlessly? A key goal is to fuel innovation in the home use of medical devices through person-centered design. MedTech solutions play a key role in turning the tide against the burdens of chronic disease. This includes treatments and cures, as Malvina described earlier, but we also know we need to look earlier in the disease process. Consider the role of MedTech solutions in extending the reach of effective tools for screening, monitoring, or diagnosis to help ward off progressions into chronic or more severe stages of disease. And this is especially important when there are barriers to patients accessing traditional care delivery settings. Malvina mentioned FDA authorized devices which extend DRD screening capabilities into primary care settings. This addresses a key need, recognizing that many diabetes patients may not be able to get regular eye screenings for a variety of reasons. At the same time, there's a need to strike a balance so that healthcare resources can focus on the right patients at the right time. And the foundational clinical science has to be there to support doing this in a way that effectively can integrate with clinical workflows. As I understand it, DRD screening had these key building blocks, namely the underlying science was there to answer a key question about what is the clinically meaningful referral point for further assessment and potential intervention. Consider also at-home treatments and other products for medical care, prevention, health, and wellness. These devices can be important tools to help people take care of their own health. Consider the beneficial impacts of continuous glucose monitoring and automated insulin delivery systems. From a patient-centered perspective, then, we ask what further advancements may be needed in this area. Are there barriers to adoption of existing MedTech solutions in home use contexts? Can devices be correctly used by people with varying levels of visual function, for example? How would things like contrast sensitivity or other changes impact device usability? Now I will tell you about our Idea Lab. We created this as a resource for innovators to inspire creation of new and better solutions to help them visualize how their medical devices may fit into the lifestyles and home environments of people living with diabetes. Working with a contractor and a multi-stakeholder steering committee through a multidisciplinary discovery process, we wanted to better understand the landscape of established and emerging diabetes health technologies, clinical and lifestyle management factors, and home environment design considerations. This involved multi-domain literature reviews, housing, site visits, inputs from patients, providers, medtech innovators, and other key stakeholders. The work produced a suite of tools which are freely available on our website. You can search for CDRH Home as a Healthcare Hub Idea Lab to take a look for yourself. These tools are meant to be building blocks for inspiring new and better person-centered innovations. They include fictional personas based on real-world patient input and provider input. They are detailed personas to help innovators understand how people with diabetes manage everyday life. You can meet, for example, Sean Gomez, a 30-year-old single father who lives with type 2 diabetes, obesity, and chronic kidney disease. And to manage his health, he uses multiple devices at home, which you can learn more about from these personas. They help innovators and designers appreciate what real people living with diabetes experience when they use a glucometer, a CGM, blood pressure monitors, home hemodialysis, wound vacuums, and more in their home environments. Second, we have the LilyPad VR experience. Now, LilyPad enables designers and innovators to immerse themselves, to be invited into Sean's home, to walk through it and gain insights on the real-world challenges and constraints that people face as they manage their health in their home environments. You can see here we've included a range of housing settings. We were looking for some heterogeneity, as well as some examples of more constrained environments than we might be considering when we're thinking about clinical contexts. The third component of the Ideal Lab are what we call considerations for innovators, a list of design prompts or questions to spark meaningful person-centered medtech innovation. And finally, you can find an executive summary report of our research findings and other insights that were gleaned from our discovery phase. So to wrap up, we hope that the LilyPad immersive experience of a home environment and the other Ideal Lab tools will help innovators by inspiring new and better medtech solutions, and that the Home as a Healthcare Hub initiative fuels innovation in safe and effective home use of medical devices through a person-centered lens. Thank you for all of the work you're doing in DRD and for your interest in Home as a Healthcare Hub. I look forward to continuing the conversation. Malvina?
Thank you very much for a fantastic presentation. And now we would like to continue to our panel. And Michael and Katie, both of your presentations are a wonderful summary, leading us to conceptualize how we incorporate everything that we heard today from all of the speakers into creating endpoints fast, effective, and together, which is what CCOI is all about. So, Katie, I would like to start with you. I thought your presentation today was a very nice transition from both the presentation given today by Dr. Sahel, as well as the presentations we heard in the previous session from both Olivia and Amanda. It was very clear that, that patients with diabetic retinal disease do have significant contrast sensitivity and visual function limitations, loss of peripheral visions, and that, simulation of their gait and assessing that it has a tremendous impact potentially on the future of diabetic retinopathy disease assessment. What I was curious to ask you about is I know that the current LilyPad does not have diabetic retinopathy disease visual limitations incorporated in it. So would it be possible to simulate the progression of vision loss in the VR environment to help developers see how patients' usability needs to evolve as their condition progresses?
Well, that's a wonderful synthesis and connection to some of the really interesting real-world test environments that some of the other speakers talked about. And that's exactly what we are hoping the LilyPad will inspire. We started with diabetes, recognizing that with the prevalence of the disease, as well as the use case that includes many different kinds of existing devices, would be broadly applicable. But we do have, folks have the ability to take the LilyPad. It's open source, freely available. It can be downloaded. Anyone with the technology and the know-how could take the building blocks that we have there and extend them into other diseases or conditions. And so what you're describing is very doable with this starter material. And we're hopeful that this will help designers and innovators who are working on solutions for these technologies, new and better versions of things that are available to meet the needs of diabetes patients across the spectrum of disease, to have a more immersive experiential understanding the challenges that patients have, so they can take that learning and insight into the designing and iteration of these technologies to better serve patient needs.
And what about tying in the physical space with the VR?
That'd be very interesting. And we've had a number of different folks in different disease areas thinking about ways to connect that. Certainly, inspiring innovation and new design is one key goal of this suite of tools. But the ability to help innovators throughout the development process to think about how to evaluate how the devices fit into the homes and lives of patients, to better understand the usability as well as functionality, and to be able to test that would be very, very interesting.
Thanks. If I can just go back to your, the overall 4 points for the IDEA Lab. In light of today's conversation, I want to highlight what came across very clearly to me, at least, that it's not just the endpoints for DRD that we need to focus on. Some of the work that needs to happen is to make sure that we have devices that are cleared to assess the data that we're trying to use to assess endpoints. And I truly believe that the IDEA Lab is consideration for innovation for innovators. That's the aspect of this that I believe can simulate that going forward. So with that, Michael, I want to turn to you. I think you did a fabulous job talking about the primary endpoints, the secondary endpoints, the surrogate endpoints. And I know it's a very complicated topic. What I want to make sure that we also discuss when we talk about the endpoint development is what has been touched upon by all of the speakers today. Dr. Levine very nicely summarize that when we talk about clinical outcome assessments, we think about 4 different types. And I think you touch upon that. And I think that where these endpoints are being assessed is something else that we need to make sure that we address. So with that in mind, Michael, I wanted to hear your thoughts about remote data acquisition for DRD.
Yeah, so thank you for that. And I totally agree. And that's, of course, the best way to do this. Before we go there, however, I do want to remark that these home-based endpoints or diagnostics or treatments, it's more tricky to, as an innovator, it's more tricky to get reimbursement in some form. We see Notal, that is the home OCT for AMD, having a lot of trouble with that. And it's an exciting technology. And so that's why the CCOI is so important, because it allows all stakeholders to weigh in on this, including payers, right? And so there's a sideline. So back to what you asked, as you know, but most people may not know, is that the CCOI is being funded by FDA to look at these invisible populations which normally do not get eye care, which can be up to 70% of all patients, for example, with diabetes, do not even go to eye care, let alone be exposed to potentially participating in a clinical trial. So it's huge if we can access those populations and have endpoints that are, achievable at the home. The LilyPad is very exciting, but it wasn't, like you said, it wasn't really about diabetic retinal disease, right? But things like what Amanda, Dr. Bickett has been showing here is gait analysis, which very exciting, is a neurodegenerative, very early metric, maybe not endpoint, but it could be. And so that would be ideal. And you don't need to make any modifications to the LilyPad. It would literally be measuring right then and there while the patient is walking around, no modifications needed. But of course, you can evaluate it and see what happens. So I think those are very exciting developments. We need to be very smart about how we research the correlation with clinically relevant endpoints like visual acuity or visual field, as well as practical endpoints like, satisfaction, being able to do daily life activities, and then ultimately to be very aware that if these diagnostics exist, in some way they need to be reimbursed, otherwise it will still not be adopted. So it's a very important, very exciting development, and I hope we can do much more of this in the coming months and years.
Great. Before we leave this topic, there's something else I wanted to comment on that I thought last session, Olivia's presentation specifically touched on that wasn't really expanded, but I think has a tremendous potential, which is a formal patient preference studies. And Olivia alluded to that. And as some of you might know, FDA has guidance on it. I've had the pleasure of doing a formal patient preference studies in glaucoma, which really helped us to move some of the risk-benefit assessments much faster than could have been otherwise. So there has been a significant discussion today about PRO development, but I just wanted, before we leave the patient, the 4 COAs, I wanted to also highlight that the patient preference studies is a very important aspect that can help a number of medical products over the line. All right, now back to you, Michael. With being the pioneer with getting the IDX or digital diagnostic, as you call it now, out, not just in US, but on the other markets around the globe, I wanted you to share your experiences you've had in the different bars for acceptance of clinical endpoints by different regulatory authorities.
Yeah, thanks. And it's been an interesting road. And before we start, I want to make sure it's clear that essentially it seems there's a balance between the regulatory burden and the success in getting a sustainable, viable business model or reimbursement is called. For example, the CE mark is essentially very little clinical data. It's all about whether you have a quality system for developing the AI. It's a little bit more evidence now, but it's very, very limited. So it's relatively easy to get CE mark in our experience. It was relatively difficult, almost impossible to get reimbursement because essentially the mark is not really trusted. So you will see that then every subpopulation and every maybe jurisdiction wants to see their own validation on top of the CE mark. Whereas on the other hand, places like the US and Japan are much more rigorous on the regulatory side, but however, that makes it easier for payers or whoever is paying to accept that this is indeed a product worth reimbursing. So there's a balance to be found. You can go fast on one side and then you're slow on the other side and more difficult, or the other way around. I think what is interesting that happened, for example, in Japan, that beyond what was regulatory requirements in the US, they also looked at the comparison to, for example, telemedicine and wanted to actually see an RCT based on that, which is, of course, going to be very exciting in the future. I will be doing a congressional hearing in 2 weeks, hopefully, and we'll be arguing that outcome should be part of this because ultimately payers many times want to see outcome data, meaning improved outcomes for such technology as AI, and rightfully so probably. So there's a big landscape there, but ultimately you still need to show safety, efficacy, and ideally better outcomes to make it as easy as possible. So you're working your way backward. Why not do that? And then, it can fit in different parts of the regulatory landscape in each of these areas.
So, I just wanted to highlight that the unique aspect of CCOI is that we are going to reach global consensus for these endpoints. We want to make sure that the endpoints that we generate create a level playing field for across all of the products around the world, so that the industry going forward will be able to do one study, or at least one. It might have different arms, but one study with one set of endpoints, and knows that the outcomes will be accepted by different regulatory bodies. And it's not an easy task, but I believe that having everybody at the same table at CCOI, we're uniquely positioned to achieve that. And I'm very excited. And I just wanted to circle back to our native platform. I described that in my presentation. And the beauty of NADA is that it's consistent with CCOI mission in that we are going to be asking questions from people around the globe. It's not US, it's actually based in UK, but we will be tapping into all stakeholders around the globe. And as I mentioned, we will look forward to announcing the sessions once we have further details. But now I want to turn to the questions we have in the chat. Michael, there's one for you. It says, I like the multiple primary endpoints presented by Dr. Abramov. Does he or others have any thoughts about composite endpoints that are based on collective changes of endpoints? How about the structure function endpoint that combines RMP and visual function?
Yeah, and I'm afraid this will be so there's so much work to be done here. I totally agree. Structure function combinations are great. There will be weights, right? Because it's multidimensional. So someone, ideally the CCOI will still, or the DRD, the group you're currently in, right? Hopefully can decide how much to weigh structure versus function, because you still, if you have one endpoint, it needs to be a number or a metric, and you need to combine it in some way. So that's what I'm thinking about too. I don't have any recommendations currently that would go beyond, very anecdotal, not scientifically based yet.
Okay, thank you. There's a question here about telemedicine. Hopefully telemedicine, overwhelming healthcare workforce and system. Hopefully telemedicine will continue to help patients and healthcare workers. Okay, yes, we agree. I don't believe it's really a question, sorry, it's more of a comment. And yes, we agree that telemedicine will have a role. However, I want to make sure that when we talk about telemedicine, we all know what we're using to assess the patients. Unfortunately, very often people use devices for assessment of telemedicine which aren't necessarily cleared to or approved by FDA to obtain those functions. So I'm 100% behind telemedicine, but I want to circle back about not just inspiring people to develop novel endpoints, but also to make sure that we don't forget development of the medical devices that we need to assess the endpoints and to gather the data so that we can utilize the telemedicine. Michael, any thoughts on that?
No, I agree. And telemedicine is essentially similar to AI in that the sensors can be the same and they should be, like you say, known to be safe and effective. And then the interpretation is either a human, that's telemedicine, or AI, and it's, a computer. So there's a lot of similarities and overlap there. And ideally, we would use, similar endpoints and similar metrics, which is not always the case currently. Ultimately, this is about better outcomes for patients, and then you want to do the right thing.
So the last topic, we only have 5 minutes, I want to turn and touch upon is a preventative treatment. And I really love the concept. And I thought Dr. Levine having two patients in a different, in the different journey of the disease progression really highlighted the need for us as a community to make sure that we focus on the whole disease. And the earlier we can diagnose and intervene, obviously, the more patients can prevent diabetic retinopathy disease loss. Having said that, I want to make sure that we're all very clear about again, there were wonderful presentations today about early findings that can be or hopefully will be correlated to preventative treatment. I think before we turn those into endpoints, we need another session which with the DRD Cure Accelerator to clearly delineate what devices are currently available in US and around the globe to capture those measurements. Now, another very exciting development right hot off the press is that CCOI is hoping to become accepted by ANSI as a voting member for American National Standard Organization, and will have an ISO presence, International Standard Organization presence. So it gives CCOI a very, very unique place in the world to be able to generate draft standards for considerations by the whole international community for any devices that we as a DRD Cure Accelerator would like to see and to push forward on the international scale to be able to gather and obtain that data and get the clearances or approvals by regulatory bodies for those specific indications. Michael, I know this is hot off the press. You didn't know this, but
that is very exciting. I didn't know that.
CCOI is moving very fast, and even Michael didn't know that this is happening.
Late-breaking results.
Katie, Michael, we have 2.5 minutes. I wanted to give you an opportunity to sum up and give your final thoughts before I pass the baton.
Katie, you want to go first?
Sure, thank you. I just want to thank you again to Malvina, to the DRD Collective, and to the organizers. It's an honor to be included in the program for today. It's inspiring to see the work that you all are doing in this space to help patients with DRD, and we look forward to future conversations about ways that the Ideal Lab can be a tool to be a springboard for further innovations to help patients.
Thank you, Katie. Michael?
Yeah, I think it's so interesting. There's this spectrum, right, where I agree. I'm very excited about doing this in the home and all the things we do about gait analysis, other types of visual performance analysis in the home so that we have very early metrics, endpoints, hopefully treatments. But there's also, diabetes is partially a disease almost of more for type 2 than type 1 of lifestyle, right, of avoidable factors. And that means that even though there may be preventative treatments, they will not always be accepted or adopted by a group of patients. So I think we need treatments and endpoints along the entire spectrum. We should not forget that some people are blind, almost blind from DED, and we want to include those in what we consider. It's all of it is important. Mm-hmm. And cortical implants at one end, and very early, hopefully oral or supplement type treatments at the beginning based on endpoints. In the home, we need all of it and everything in between. So we shouldn't forget one for the other. It may just be, maybe the endpoints for NLP or LP type patients may be easier to determine, but the treatment may be more complicated. On the other hand, the endpoints for very early may be harder to define and to understand and get consensus on, but they maybe have so much more broader impact. So it's a great, sorry to go on so long. It's just a great time in being able to influence this.
Thank you very much, Michael. I want to thank Robert for being such an inspirational driver for the DRD Cure Accelerator. It is truly awe-inspiring what MTM Vision Accelerator achieved in a very short time. And I'm really, really excited with partnering with them to make sure that we can continue on his very expeditious journey to cure DRD. And with that, Tom, for your concluding remarks.
Well, thank you very much, Malvina, and particularly to everybody involved today, and particularly the partnership between CCOI and the FDA. So this journey where we are today to a Cure Accelerator began in 2018 when Robert organized the first moonshot meeting in New York. 4 years later, Robert officially declared war on vision loss from diabetes in the formation of the NTM Vision Initiative. And today, after really just 4 years, it's incredible how we've come to what I would submit is a landmark event where we're actually are moving. We're still doing science, we're still doing discovery research, but we're also beginning to formulate a very potent and practical outline of what we can do together. Obviously, the main focus here is on patients, that began with Mary and now is about all the patients like Adriana, Chris, my two brothers. And so there's a great deal to do. I would submit that we really need to keep working on, first of all, understanding what we do not know, which is considerable, but also to really organize our activities so that all the various parts of this enterprise keep working together and synergistically. So again, thank you very much. And so we've challenged ourselves, and hopefully, and there's no doubt that we will continue to make progress. And with that, there's nobody more fitting to say the last word than Robert.
Yeah, thanks. Thanks so much, Tom. Thanks, Malvina and Michael, and everyone who's participated today, who's joined us and has presented and joined our panels. I will say this. First of all, I absolutely agree with Michael's closing notation. When we organized this, as Tom said, we called it the Restoring Vision Moonshot, and our mission clearly stated it's about preserving vision in people with diabetes, but also about restoring the vision in those who have lost the vision. So we do look at the entire spectrum, of the disease. And I just want to use, when I first presented this in 2018, one of the quotes that I looked to, one of the inspirations was, of course, President Kennedy's original moonshot. That's why we called it the Restoring Vision Moonshot. And what he said in September of 1962, I think fits us very well. And in his speech at Rice University, when he was trying to defend his decision to launch the mission to the moon, JFK said this. He said, "We choose to go to the moon in this decade and do the other things, not because they are easy, but because they are hard. Because that goal will serve to organize and measure the best of our energies and skills. Because that challenge is one we are willing to accept, when we are unwilling to postpone, and when we intend to win." So I adopted that. We adopted that with the Restoring Vision Moonshot, which we now call the Mary Tyler Moore Vision Initiative. It was organized to honor Mary and to help make her dream of a world without vision loss from diabetes a reality. And again, it does go to, all these sorts of efforts are personified by the people who lead them and are a part of them. And so if I think about Mary, I always think about Mary as a dancer. And what Mary understood, as a dancer, was that to achieve anything that's never been done before requires real passion, a clarity of vision, discipline, a willingness to take risk, a context of real collaboration, and a clear understanding that in order to succeed, your toes are likely to get bloodied. So we're all here together today, willing to do the hard work, willing to have our toes get bloodied in order to achieve that ultimate goal, as Malvina put it so well earlier, that we're going to cure vision loss from diabetes. Thank you all so very much. Oh, and I should mention, we have our fourth annual symposium on curing vision loss from diabetes, again in Ann Arbor this year, November 2nd and 3rd. We'll hope to see you all there. And thank you.